No, absolutely anybody. Usually not the two people. Focus on these, but. Thank you very much. I hope everyone enjoyed their lunch. We're going to start the afternoon session. The small change to the agenda where I've added a break. There's two components here. We're going to, the panel will ask questions of the presenters who've been nice enough to sit here in the front row or near the microphone here in front of me. And then we will have an open discussion in the tradition of a FACA committee between one another. After that, we're going to take a 10-minute break, which I'm estimating to happen at about 2:15. So, but we'll obviously see how this all goes. I would just ask that as we ask questions of the presenters, I've spoken with the panel in advance and also today to ask questions that are precise as opposed to making statements. I will similarly ask the presenters. There will be ample opportunity to provide more answers, but please provide answers, not sort of use the mic as open mic night, if you will, unless you have something really funny to say and you're not a Wolverines fan. So anyway, I will start with Dr. Carr with a question for the panel, and then can I ask members of the panel, since it's hard for me from here, just turn your tent card so I know you have a question if you do.
Okay. This is for Dr. Beckman from the American Heart Association.
I'm sorry, Dr. Beckman is actually the only speaker who's no longer here.
Okay.
So,
well, probably. Let me go through the presentation. Well, how about Dr. Bartholomew? So the question is, we saw a lot of data on asymptomatic peripheral arterial disease as being underdiagnosed. And what are the opportunities for further refining that? In the public comment, there was one individual that stated that she believed that some of that was undiagnosed, that there really were symptoms in that. So I guess the question for you is, what is the feeling for further identification of people with asymptomatic peripheral arterial disease, and are there primary and secondary prevention strategies that might work?
So I think one thing is what is asymptomatic, and peripheral arterial disease, we always think of it, these symptoms as intermittent claudication, but the majority of patients that you've heard today don't necessarily have intermittent claudication, or for the audience that's usually described as pain with walking or discomfort usually in the calf or the buttocks or thighs with walking. So I think one thing that we might need to do is also to educate physicians and caregivers and how to perform the ABI, at least to make that diagnosis, because I don't think everyone knows how to do that. Or another simple thing that I know that some colleagues of mine have done is to educate caregivers how to detect a pulse, simply by teaching them the simple procedure of palpating a pulse in the dorsal pedis and the posterior tibial artery. So I guess those are a couple things that one could do to educate the public more on what is PAD, and as far as asymptomatic PAD, and answering your second part of the question, if we do, and I guess we would define that as an ABI less than 0.90 would be asymptomatic PAD, at least by my criteria. But I think that some of the things that can be done to prevent complications are not only once you recognize that, would perhaps do certainly monitor the individual's blood pressure, check a lipid panel, and advise them to quit smoking. But certainly the guidelines would suggest if you had officially diagnosed with PAD, you'd want to get the LDL cholesterol under 70. You'd want to make sure their blood pressure was 140/90 or lower. You would want them to quit smoking. You would like them to follow a good diet, a low cholesterol diet, and exercise regularly. Did that answer your question?
Thank you.
Thank you.
Yeah, okay. Yeah, please introduce yourself, Joe.
Joe Chin, the Deputy Director in the Coverage Group. I just wanted to clarify a comment about the ABI, specifically for screening in asymptomatic patients. Our authority is Medicare's authority to cover preventive services based on one of the criteria is a A or B grade from the task force, the U.S. Preventive Service Task Force. And also through an NCD, it has to be reasonable, necessary, and appropriate for the Medicare population. For us to actually cover specific screening with ABI. Right now, it's not recommended by the task force. So there is no mechanism right now to cover screening for peripheral artery disease with ABIs.
Can I ask you a quick follow-up question?
Yes.
Please.
Yes.
That as the
You
speaker...
can stand there as long as you want.
Yeah. No. If somebody doesn't have a pulse, that would mean that it was then a diagnostic test under your reasoning?
Right. So typically the way we define asymptomatic is that there is no sign or symptoms of that specific disease. So if basically if you're not detecting a sign or a symptom, that's how we classify it. If through your regular exam, when you find a finding, for example, a wound or an ulceration, and do an examination and detect a lower reduced pulse, that's more diagnostic. Thanks.
Dr. Deo, question?
Yeah. Question for Doctors Jones and Patel, if they're here. Yeah. You reviewed the efficacy of a couple of different types of medications, but there are some things that I see coming up in various guidelines, including ACE inhibitors, statins, and so forth, that you didn't cover. And I'm just wondering if you're aware of clinical trials of those agents specifically for peripheral artery disease.
Thanks. And so I think, and Scholar, you can jump in but the guidelines are based on several cohorts of patients with PAD and larger cohort studies that have coronary artery disease and were being evaluated. So for example, the ACE inhibitor, some of that data is from, for example, the HOPE trial where ACE inhibitors were used in diabetic patients, some of whom had PAD. And so there's subgroup analyses of those data. Data for specific populations where it was just studied as the primary prevention in only PAD patients, diagnosis with an ABI or something. I'm not sure of a direct large cohort study. Aside from some of the antiplatelet studies we discussed, the statin and the ACE inhibitor data is based on larger trial data where PAD is represented as cohorts of those patients. Does that answer your question?
So it sounds like that evidence is mostly from other types of vascular disease, really.
Yes.
Certainly there was, like you've heard for a lot of primary prevention or secondary prevention, these PAD observationally has been known to be a cardiovascular risk equivalent, and then, as you said, it's observations of other trials with patients that have a broader population than just PAD.
Okay.
But some of them obviously may be undiagnosed or diagnosed.
Thank you.
Yes, Dr. Lefebvre, can you put up your tent card if you have a question? Dr. Zuckerman, please.
Also for the ARC presenters, you had so much data and it was very hard to keep track of everything. I did have a question about when there's inconsistency between data showing improved quality of life, and I think we'd all agree quality of life is really important, but quality of life and pain both being very subjective compared to some of the other measures. And were you able to have any determination of placebo effect? Were the controls adequate to get a better sense of to what extent when there were inconsistencies it had to do with potentially with a placebo effect as opposed to an impact of the actual interventions?
Yeah, thanks for the question. I think when we really constructed the questions, it was hard to figure out how to evaluate differences in usual care and or placebo compared to the interventions. And so what we had to do based on the available evidence was actually look at specific interventions compared to those things. There was no clear evidence that a placebo effect existed. However, we all know that in many of these cases they do. We just weren't able to detect that. And so along with heterogeneity, along with mixed populations, it was very difficult to tease that out. Not sure that answered your question, but that was the difficulty in trying to determine that.
So just to follow up, so it sounds like you didn't try to take that into consideration as you interpreted the strength of the relationships?
Right. So I guess what I would say is that qualitatively we were able to determine that there is a likelihood of that, but quantitatively there were no methods in a fixed effects or network meta-analysis that we could do.
Okay, thank you. And if I may, I had another question for you, and that had to do with some of the, I just want to make sure I was clear that when you updated your analysis and you looked at new studies and you didn't look at them exactly the same way, you didn't include them in a meta-analysis or another, you just looked at them. So I'm assuming that when you looked at which studies were the best and so on, that the results were consistent with the previous results, or you would have said so?
So, yeah, one of my slides said there was limited evidence to suggest that there was that the new evidence would suggest a difference in what we found, given the comparisons that we made, and given the fact that 3 months ago we didn't know this was occurring. So we did a very, I would say, rapid review of the almost 2,000 articles. And a qualitative, not quantitative, review of that evidence. But from a qualitative standpoint, I would say it does not suggest that we would have concluded anything differently.
Yeah, I'll just make one clarification too. In our, and some of the other points too, our analysis is very specific at comparative strategies of endovascular versus medical, or endovascular plus exercise. So some of the data that was excluded may have been newer therapies within one strategy. So that, I think, should be clear. The second is, I think another way of saying qualitatively is to say that we wouldn't have suggested from the data we saw that the point estimate was going to change qualitatively compared to what we saw.
Thank you.
Great. Dr. Sujet?
I have two questions. One for Dr. Ansel, kind of tweaked my curiosity. I did not know that Italy has the lowest amputation rate in the entire world, but it reminded me of Ansel Keys' original 7-country study from the late 40s or early 50s, where they plotted cardiovascular disease from the Mediterranean basin north to Finland and the higher saturated fat diet. So is there an explanation for why Italy has such a low rate? Is it diet related? Is it lifestyle related? What's the explanation for that, if we know?
Thank you very much. So Italy has 3 hospitals that focus on critical limb ischemia for the entire country. So they're high volume institutions that do exactly what we've been talking about here, which is use a cooperative, integrated approach between the different specialties. So these patients have very focused clinics, but they're very aggressive, and their number of endovascular procedures has skyrocketed in the last few years. They've actually led the world in how to get through these small vessels. They've been teaching us how to go through toe vessels to get blockages opened up. So it's a very aggressive country from that standpoint.
Okay, and that second question relates to, I guess, Dr. Cronenwett can answer this best. In my former life, I was a chairman for an Institute for Health Equity in Nassau County in Long Island. Depending on whose numbers you believe, Nassau is either 10th or 11th in the country in terms of median income, so it's a very wealthy county. But within that county, we have communities, predominantly African-American communities like Roosevelt and Hempstead and Uniondale, where the lower extremity amputation rate was 2.8 times compared to the North Shore LIJ system. So I've seen these maps where the amputation rates are high. It's not frequently appreciated. About 70% of US blacks live in 10% of US zip codes, about 3,000 zip codes. If anybody has mapped those areas of high incidence of amputation rates with the zip codes and what the demographics of the zip codes are, and if that holds up, Gary Puckerham's done some interesting stuff with this, but this Vascular Quality Initiative looks like a method, I'll put my public health hat on now, where primary prevention beats everything else out of the gate in terms of secondary and tertiary intervention. So has anybody drilled down on that data to look at it?
I don't have that answer, but I think these guys are pointing at each other, so I'll let them do that.
There are, as you saw this morning, there were several slides presented that correlated both race, socioeconomic status and amputation rate. And that's been done by several people, and there's a pretty high correlation across the U.S. The explanations aren't completely clear about whether it's late presentation or late diagnosis or other biologic factors. But in VQI, we do have the ability to look at patient zip code and obviously race ethnicity and correlate it with imputed socioeconomic factors to try to answer some of these questions. But we haven't focused on that yet as a particular initiative.
Can I just answer one addendum? Because one of the things we found is people refer to access. There's two kinds of access. One is when you get your foot in the door. The other access is what happens on the other side of the door. And so that's why your intervention tweaked my interest, because that's where the rubber hits the proverbial road in terms of what happens to the patient when they access an encounter with the healthcare provider.
It's a
Frequently,
great,
that's the deficit.
it's a great question and a great opportunity for us to look at.
Okay, thank you.
Great, thank you. CAS panelists, if you've asked your question, to put your 10 card down. If you have additional questions, that's great. Dr. Campos Outcold.
Yeah, I have a question for Dr. Jones and Patel, and then a question, follow-up question after they respond to that. My first question, the next question would be to Dr. Turco. So Dr. Turco mentioned a number of studies that he felt were not included in your assessment. Could you comment on his comments, please?
This should get exciting, I think. So I think rightly so, Dr. Turco is pointing to several studies that have occurred in the last few years where specific interventions, potentially in the endovascular space, were compared against each other in a fairly rigorous fashion. As I stated just, I think, a few moments ago, our analysis starting with AHRQ in 2012 and even our update was looking at sort of larger strategies, looking at endovascular plus exercise therapy versus, say, exercise therapy alone. So when we did the update, we saw some of those randomized trials and others, but they were excluded as they would have been excluded from 2008 to 2012, again, because they didn't meet the key questions that we were addressing during that time point. So it should be important to recognize that the HRQ evidence base doesn't speak to specific interventions within, say, endovascular surgery or other types of potential interventions.
Okay, so my question then to Dr. Turco is that you mentioned that I forget the number of studies that you mentioned, and then you said that they were rated at a level 1 evidence. I'd like to know what criteria you used to get to a level 1 evidence, who made that assessment, and whether that assessment is open for scrutiny for outside groups.
So what we had looked at, and thank you for the question, was since the AHRQ report that came out in 2013, 2012 was the stop of where the cutoff for the studies that Dr. Jones and Dr. Patel looked at. There were 35 additional studies. Of those 35, 20 studies looked at endovascular versus endovascular interventional procedures, and they were excluded by definition because it was not comparing to, it was comparing to another comparative treatment group. So there are 20 studies just in the newer endovascular treatments that were excluded from that, that data set, which I think is critically important when you folks deliberate and look at that data. All of those 20 studies, all of them met every other criteria for inclusion from rigor within the AHRQ data. So they would have all met level 1 evidence and rigor as randomized controlled trials that fit the criteria for the AHRQ. So,
and who conducted that assessment, and is it open for review?
We could provide it for review. What we did as the consortium of the 5 companies that work together, we actually asked Boston Healthcare to basically conduct that independent assessment, and they provided that independent assessment to us for review and then presentation here today. And I can check as to whether we can provide all of those, that data set to you, and I think we should be able to do that.
And what level of PAD were those studies on?
So it goes across the board in intermittent claudication, chronic limb ischemia, and then also a mixed population of chronic limb ischemia and intermittent claudication. So it was across the board in all three categories of those patient populations.
And actually, can I ask a follow-up? So I'm just trying to understand the inference of those within endovascular intervention studies. Is it, and I'm not going to try and put words in your mouth. I'm going to throw out an idea and then tell me if I've got it all wrong. Are you saying that the newer devices that were constituted one or more arms of these trials relative to the comparator would move the mean effect within the category such that the ARC report would have a different conclusion?
So it's
another way of saying it is that you're saying endovascular interventions are better on net because of these new devices to an extent that these conclusions would be altered.
So just one thing, Dr. Schuyler and Dr. Jones did a great job with the report. So none of this
everyone
criticism
appreciates this
of
is
that
an
report.
academic discussion.
So one would need to go back and do that assessment. Looking at the results of those particular trials, I would assume, and it's my own personal feeling, that the level of evidence would change in the AHRQ report if we were to add in some of those missing pieces of information. Again, that's almost 25,000 patients that could have been added back in. Now, the other point to consider, which was one of my next to last slides, is that there are 9,000 patients almost that are being studied, close to 9,000 patients, on even newer technologies, with those trials looking at endpoints out to 5 years. So truly durable results out to 5 years. So that could be an additional 9,000 patients that are added to the information pool and evidence pool looking at intermittent claudication and chronic limb ischemia.
Can I ask a follow-up question?
Sure. Is your follow-up question on who is?
Yes.
Marcel, it's on the same topic?
Yes.
Okay. Please go ahead, and Dr. Jones or, okay.
So I did appreciate, Dr. Turco, the comment you just made about the ongoing trials for newer technologies. But I looked at your slides, and many of those studies are not randomized trials. And could you comment on why that is the case? They are mainly one-arm studies, I guess, of the device under investigation.
So it's hard for me to comment on all of the other industry trials. If you have a particular trial in mind, we do have representatives from Bard and Gore, Boston Scientific, and Abbott here that can comment. I can certainly comment if you have a specific question about one of the trials that is a Medtronic-sponsored trial.
Well, okay, you listed 35 trials or something that are ongoing, and I appreciate that. And you said there's 9,000 patients in those trials, but most of them are not trials, and most of them are observational studies, and one is very much driving that 9,000 number, because I think it's one of yours of 5,000 right there. So many of them are small single-arm studies, not randomized trials. So I'm not sure why you think that would drive some of this.
Well, I think, again, we have two separate topics. We have the newer trials, and then we have the body of evidence that is already in the literature that is peer-reviewed from 2012 to the current time. So we would have to see what happens with the newer body of evidence, but we do have 25,000 patients, patient-level evidence of rigorous evaluation that could be added in to the totals. With regards to your question, I agree with you. Some of those trials are observational and single-arm trials, but there are also very large trials in there that are randomized and meet the rigorous criteria that AHRQ has set forward, and I think are worthy of inclusion and consideration.
And one last question.
Hold on, Marcel. Hold on a second. Dr. Jones has something to say as well, so go ahead.
I'd just like to say I don't disagree at all with Dr. Turco. This is about how you slice the pie, slice the data. So when we were asked by AHRQ to do this evidence review, if we had 5 years and 50 people and $500 million to slice this data, we could have sliced it in every single way and looked at each of the comparisons. We did very broad strokes or very big pieces of pie to look at the comparisons that we presented, and part of this I think may have been how I presented it. We also did a separate review of supervised exercise and home exercise, which is a subtopic. We could have done angioplasty versus stenting versus atherectomy as a separate topic. We could have done surgical techniques as a separate topic. So this is how you slice the data as much as it is about the data itself.
Great, thank you. Dr. Swain.
I had one last.
Oh, I'm sorry. Go ahead.
Which was
Dr.
just
Sleeve, go ahead.
about the small studies of new investigational devices. So it would seem to me that those would only provide safety data. And is that true, or are they really going to provide some data on effectiveness of the devices?
It's hard to take a broad swath without looking at each individual study that you want, are trying to consider. Certainly if these studies, you have to look at both safety and efficacy if we're trying to change a label or trying to get a United States approval. So I think some of those would probably be looking at both aspects. If it's just kind of a post-market evaluation that is in that list, and in particular, that may be looking purely at a safety indication. But your questions, I think, are very valid. I would, however, suggest that the large pool of evidence there since 2012 does have some rigorously controlled trials that, if we just exclude those patients with new endovascular and endovascular evaluations, I think it would give us a misleading interpretation of the level of evidence that's available for our patient subgroups.
Thank you. My apologies, Dr. Swain. Dr. Kormos is next.
Thank you. I enjoyed this today. This was really an eye-opener, but it opened my eyes to a greater problem in cardiovascular disease. And my question relates to the first challenge that we have in asymptomatic peripheral vascular disease. I'm going to direct my question to Dr. Bartholomew if he's here. You gave a very impassioned plea for us to take a close look at the fact that undiagnosed peripheral vascular disease is rampant. And I'm gathering that argument was made because we need to look for it. And to look for it, ABIs is probably the only thing that you have right now that would do that. But my question is to you, are we looking at ABI as a surrogate marker for cardiovascular disease in general? Because what people are dying from aren't their legs necessarily, if you find something on an ABI. They're dying from cardiovascular disease and strokes and other things. So I'm trying to put this together. There's a little bit of a disconnect here. How do you then present this case for a better study or assessment of cardiovascular disease in patients such as those that smoke and they have diabetes, they're obese, et cetera, et cetera? Because isn't that really the challenge, is to pick this up in some way that you can then add the lifestyle modifications that you're going to do if you picked up an ABI that was abnormal? Because what I'm a little bit thinking as a second part of my question is, how do you keep people from doing something when you find an abnormal ABI? How do you keep that chain going down the road of then doing an angiogram, doing a vascular study, and somebody says, oh, well, there's a 50% lesion, let's open it up. I know there are guidelines, but there's also a rampant increase in procedures. So the first question is are you using ABI as a marker for cardiovascular disease, or is this specific for the vascular problem?
Well, we routinely perform an ABI in our vascular medicine clinic on all our patients. And we, again, use it as a marker for pan-vascular disease. We think of each individual who has an abnormal ABI as likely having some cardiac problems or cardiovascular disease or even cerebral vascular disease. So I'm not sure that I'm answering that exactly how you wanted it, but that's how I I work with my patients with an abnormal ABI. Now, that being said, I always go back to a careful history and physical exam as well. So if we're thinking about any type of intervention, if they're asymptomatic with their PAD, certainly that individual does not need an intervention for their lower extremities, certainly at that point. But on the other hand, if the ABI is abnormal and they do have claudication or do have a non-healing ulcer, that's a different story. As far as looking at the rest of their anatomy, I mean their heart or their carotid vessels, again, I think it's a careful history is important. I'm questioning the patient about any cerebral vascular symptoms to see if there is a suggestion of carotid disease, loss of vision, difficulty with speech, arm or leg weakness or anything of that lines, and then again a careful history of their cardiac status as well. So again, an ABI may be an indication that that patient has panvascular disease if it's abnormal.
But you're doing this in a vascular clinic.
Mm-hmm.
If this gets approved, are you going to say it's approved for use in a vascular clinic, or is it going to be approved by a general medicine general practitioner where you're going to get millions of ABIs being done because it's paid for? But the question is, then what do you do with it?
Well, again, I think it doesn't have to be done in a vascular clinic. I mean, I think, if I may use Dr. Hirsch as an example, he's long promoted the use of an ABI for internists, family practitioners, and other individuals. It's a very simple test to do, but I think it gives us a lot of information by having that abnormal ABI. So I think that knowing that there is peripheral arterial disease, again, translates into the thought that that individual may have panvascular disease.
Rick, can I come back? Dr. Swain is next, and then we can call.
Yeah, the interesting conversation there. I do have a question for Dr. Turco, but for you, the question is
trying
that
to escape here.
You have asymptomatic
Should we get him a
patients.
chair? Or?
Yeah, keep standing.
I'm from Michigan, by the way.
Asymptomatic patients that get ABIs, and then you tell us that it's, many patients don't have typical claudication, limitation in walking. So if you have some, and I could elicit, I'm sure, a symptom of from every single person in this audience of something relating to their legs. So you have the practitioner, primary care practitioners who get an ABI, and there's something related to your legs jump or something. You don't think that's going to lead to overuse? And it's not like atypical angina. As a cardiovascular surgeon, I tell you, that's a different, you can't compare it to that. So that seems to be an issue.
Well, I mean, I actually think this should be a part of a physical exam that patients perform. If you're going to do a complete physical on an individual, I think it's such an easy test to do, but it has a lot of rewards if it is abnormal. And again, going back to saying I think general doctors should do it, internists, advanced practice nurses. And I don't know, will it really result in overuse? I don't know how you can overuse something that has so much information. How could one overuse that test?
Of what that might lead to.
Oh, I see.
Yeah,
well, then more education, of course, must come with that. And that means that just because the abnormal, I can remember actually going back to my first day at my first job, and I'm a hematologist by training, and where I went in Michigan, they didn't have enough work for me, so they sent me off to a general clinic. And I went in and I tried to feel the pulses on this person's legs. I couldn't feel them. I panicked. I called a vascular surgeon who said, don't worry about it, take a good history and physical. And he said, do an ABI. Well, I don't think I even knew what an ABI was at that time. But, and I said, well, gee, ABI, what is that? And he translated it for me in English, and I was able to understand, and I performed it, and certainly I felt more reassured. So I think, again, education must go along, but I think the ABI is a very valuable tool. Okay?
Thank you. So the question I actually had for Dr.
Hold on, Dr. Swain. Rick, do you have a follow-up? Dr. Deo, do you have a follow-up question?
A quick follow-up to that. As a primary care doc, I routinely ask essentially every patient, do you smoke? I follow guidelines for screening for diabetes, for high cholesterol, for hypertension. I intervene with all of those things when I find them. What would I do differently because the ABI is abnormal above and beyond those things?
Well, again, that implies that patient has vascular disease, and I think, many people smoke. They think nothing's going to happen to me. My cholesterol is a little bit high. I'm overweight. I don't exercise. But if you tell them that they have peripheral arterial disease. First of all, they won't know it because they don't recognize it. If you'll recall my slide, 80% of people don't know what PAD is. But then as you explain to them that this is a pan-vascular disease, it may imply they have a more serious problem. I think that may make a difference. You have a marker for them. You have something that you can put down that says your ABI is abnormal. That means you have some blockage.
So the interventions are the same, but you think the compliance from patients would be better?
The test results of behavioral intervention, I think, to translate.
I think it might.
Let me just, the AHA guidelines, ACC guidelines 2013, if the risk, if you have a risk marker for coronary artery disease, then you might intensify to statin therapy or a variety of things. So documenting the presence of subclinical disease could change the dynamics. I don't know, Alan, if you want to.
I'd be happy to make a comment. What would
Wait,
change...
Alan, no, I want to try and maintain some sequence based on questions, but we will have chances to come back, of course, to these things. I hope that's all right. Dr. Lefebvre is next.
Thanks. So I had a question, actually two questions about the populations in these studies. One for question one, one for question two, because I'm trying to understand the results in terms of, in relation to the population that was studied. So in question one, we're asked about the efficacy of antiplatelet agents in asymptomatic PAD. And so my question is to Dr. Jones and Dr. Patel. In these studies, was it simply patients, were these healthy patients or patients from the general population who were then screened for PAD and found to have asymptomatic PAD without other risk factors? Or were they somehow chosen first for other risk factors? And the reason why I ask this is because I think what we know about antiplatelet agents is they have some efficacy for preventing coronary events. We know they work better in secondary prevention than primary prevention. We know probably that your risk of coronary disease is probably a big factor in whether they work. So I'm trying to understand the risk of these patients in the population. Were they patients with ABIs of an average of 0.9 without other risk factors, or were they very severe PAD patients with a lot of risk factors? And would that have influenced, do you think that might have influenced the results? And the second comment I had is the difference between those studies and the secondary analyses of the RCTs, like the Capri study, which I assume the Capri study was patients with CAD, if I'm not mistaken. So those were, again, patients with CAD plus PAD, which is probably a particularly severe population. And so I'm wondering if you can say something about the effect in those studies in relation to the population, and do you think there was an influence there?
Sure. So because of our effort to identify modifiers of effectiveness, we looked at all of those things. Unfortunately, they're poorly characterized in many of these studies. What I will say is that PAD was used as a risk enrichment criteria in many of these cases to get into these studies. But you're right, Capri and other studies, they involved patients with vascular disease or coronary disease or both.
Yeah, I might be. So for the aspirin versus placebo asymptomatic patient trials, it wasn't just an ABI, it could be risk enhanced. So it could be that they have diabetes, hypertension, and a diagnosis of PAD, for example, or patients that were felt to be at risk for atherosclerotic events because of age. So there's a broad inclusion set of criteria, some of which included PAD, defined variably across the trials, which were put together. For Capri, that's a secondary study of a larger randomized control trial where patients, some had prior MI, some had prior stroke, some had PAD. The PAD patients had overlap sometimes with other vascular diseases. There are probably a few patients that just had PAD in there too. So the subgroup again represents an amalgam. We didn't find a statistical finding that we could show because it's poorly characterized, as Dr. Jones has said, about the disease severity. We've showed you other observational data around disease severity, but in those studies, again, because of the way they were characterized, there's not a tremendous information on lower ABI, more symptomatic patients, and let's say antiplatelet agents. Regarding
so you would guess that in those studies, you would guess in those studies of asymptomatic PAD patients, there was a range of severity you would guess is mixed in.
That's right. So it's not that we can give you such a well-characterized asymptomatic patient population has been described. And to Dr. Carr's point, simply that, again, from the secondary statin studies and others, PAD is considered a CAD risk equivalent. So if you did identify it, you might push their LDL target lower or use more of a high-intensity statin.
Okay, my second question about the population is in key question 2. Now, this relates to the studies that compared exercise with interventional therapy. And my question is, I mean, the guidelines for interventional therapy also you have to fail exercise first. So my question in these studies, are these patients who initially present with symptomatic PAD and then you choose a treatment, either non-operative or operative, or are these patients who have already failed exercise therapy and then are randomized to either continued exercise therapy or intervention? I think that would be a very different population.
Yeah, to give you a background, and some of our technical expert panel is actually in this room who helped us form this question. We really wanted to look at are these patients who underwent exercise and failed, and therefore this treatment strategy is what we were comparing. We couldn't find, there just wasn't available trial evidence or study evidence to look at those specific things. And so when you look at the guidelines, the ACC-AHA guidelines, it's failed to benefit from either medications or exercise, or the risk-benefit ratio favored revascularization. And so I would say that in many of these cases, we don't know if they had failed exercise and then went on to endovascular. All we were able to do was, when they actually stated their results and say their methods, say that this was endovascular and exercise, and this was exercise, and we compared those findings, or endovascular versus exercise, so on and so forth.
That's exactly right, and I just might say one thing. It seems less likely that they're going to be failed exercise patients because we believe that investigators would likely document that or describe that for us. So we don't have it documented, so we can't say either way. But if you went to the trouble of ensuring that patients had failed supervised exercise, you would likely produce that information in your journal article, because we believe that would raise the impact and show that you're being guideline-based. And then second, as many of people have mentioned, supervised exercise has not been reimbursed, and so a lot of this trial evidence is probably based in clinical practice.
Dr. Lawrence, please.
Yeah, from the perspective of the public and many of our specialists and specialty societies who presented here, there's been a great concern about the overuse of procedures, particularly in patients with claudication. So I'd just like to ask Dr. Carr questions related to the freestanding centers that he mentioned that he represents, and just the philosophy about whether or not you believe that all specialists should be able to treat PAD. If you are a primary care physician or an interventional nephrologist or a psychiatrist, my understanding is in a freestanding center that there aren't the same privileging criteria as there are in a hospital. So first, who do you think should be treating these patients? And secondly, as far as practice guidelines or standards, do you believe that there are a certain range of ABIs that should be used as criteria, as well as symptoms of leg pain, to control the overuse of procedures, particularly for claudication?
Well, thank you for your question. It's an excellent question, and the reason I stand here is because we care about that, and we established a society to do exactly that. As you know, the office space, the interventional space has grown over the last several years, and many like-minded physicians came together to establish guidelines, to establish standards, and set the bar. And we feel very, very strongly as a society, the OEIS, that we set the bar and match established guidelines and proof of therapy. As far as other participants, certainly qualified physicians should be performing these procedures by all means. And most of our physicians are members of established societies represented in this room already. We follow and adopt those. We don't have a mandate yet because we're new. We have designs on creating our societal standards for an office-based location side of service, because we know that presents unique needs and controls and insurance that the patient is safe and secure, going to have an effective, safe outcome. So that is in the works right now. We have established statements of quality, and we have encouraged accreditation of every facility that is operating. We are moving toward a more and more certification process, but again, we're young, and we're moving very quickly in that regard.
So just to follow up, to be clear, so should CMS be reimbursing someone who has had no training in vascular disease management or procedural endovascular. I just used as an extreme a psychiatrist, or someone who has had we know has had absolutely no training in that. Is your society believe that those people should have privileges or be allowed to do them on in a freestanding facility, or should they have to join a society or demonstrate expertise before getting reimbursed by the federal government for endovascular procedures?
We firmly believe that operators should all be trained, formally trained in doing these endovascular interventions in an office setting. We clearly believe in that. There are established specialties that warrant that and have training programs, and there are certainly outliers that are entering in the space that we're very careful to assess their qualifications. But I believe everyone should be qualified if they go through a training program. We have vascular medicine folks that get into an interventional program, and are we going to restrict them because of the type of specialty? I think that you need to prove adequate accredited training to do this. And I think as far as reimbursement goes, I think what we hold for institutions should be mandated for everyone. And so I think we would like to partner and educate more and more about the value of this. It's a preferred site of access for most patients because of the ease of use. We see this also as an opportunity for access. We talked about the disparity of care amongst different areas. And by having office-based local interventional facilities, we believe strongly that we can assist with access. But we appreciate exactly what you're saying, and we're moving very quickly as a society to set those standards.
Thank you very much. Dr. Swain, you had another question that I...
Yeah, it was a follow-up to the first set of questions a while ago from Dr. Turco. Two things. One is you mentioned that you've got all these studies going, and again, registries, even a couple thousand in registries, are not going to be hugely helpful in comparative efficacy and safety. But I've seen a lot of KM curves today, and only a few had confidence limits, and a few less than that had N's at 5 years. One of them, I think, has an N of 9 patients or 16 at risk or something like that. So the idea that there's 5-year data available is questionable. Do you know how many of these patients have a considerable amount of data out to 5 years, like over 50% in a study? So you can say something about it, durability?
Yeah, so I can speak to the durability in our particular DCB trial. So to give you an example, so if you take the IMPACT Medtronic drug-coated balloon trial, we will be presenting this year data out to 24 months, and we will continue follow up on those patients. As the years go, we'll have more and more data. The data is still somewhat incomplete, and I think, in the PAD space, we all need to realize that, maybe in contradistinction a little bit to where we are in the coronary space, and we're still a little bit immature. And the beauty of I think what I tried to show on that last slide of the 36 trials that are ongoing, 9 of those 36 are truly randomized controlled trials looking at endovascular interventions that have mean follow-up out to 3.8 years, and will follow those patients anywhere between 3.8 and 5 years. So we just probably need to be a little bit patient to be able to get some of that long data around the durability of some of these procedures. But if you take drug-eluting stents for the periphery, if you take certainly bare metal stent data, self-expanding bare metal stent data, if you take some of the graft data that we have, and now 2-year data on drug-coated balloons, we're starting to get that longer-term data that patients want. And if you look even at the 12-month data, comparing endovascular to endovascular technologies, take a look at the patency rates and the revascularization rates. If you take just our particular DCB trial at 12 months, you see a target lesion revascularization rate that is at 2.4%. That's hard to beat in an intermittent claudication SFA population.
That actually brings up the point is your slide 10 was, I think, the meat of it. You compare 6 different trials, and there's no way to put it up there now, and you've got it out to 0.1% results. And unfortunately, when you showed that slide, and it's not your fault, the footnote was off the bottom of the screen. You couldn't see the footnote. And the footnote says the definitions for these are comparing out to the 0.1% level. The definitions for primary patency and TLR and analysis windows were different varied from trial to trial, and data is presented for illustrative purposes only. What does that mean when you're presenting 0.1%? And I kind of viewed the presentation as a criticism of the Dukies for not including this. So, you know, these are not data that I would view as quantitative data.
I never criticize the Dukies except in basketball, which we you know, that's the only time we criticize them. But Dr. Swain, I think you know your pushback and comments I think are valid. But realize that when we try, it's like putting together a meta-analysis. You know, you can only try to compare apples and apples. So in the consortium of folks that I stood up here today to try to represent, we have industry sponsors from 5 different companies that were running 5 different trials. We are now trying to bring uniform definitions to things like patency and so forth so that we can understand them better. And your point about Kaplan-Meier, is Kaplan-Meier the best way to look at some of these results, or should we be looking at other indices for patency and absolute patency as opposed to looking at Kaplan-Meier patency and so forth? So your point of that one slide 10, I believe it was, where it had, you know, the eight or so trials, 6 that had very significant p-values in most of them going out to, you know, 0.001. They are comparing somewhat, you know, different entities, but it was illustrative of the fact that they were comparing endovascular to endovascular treatments, and they were very statistically significant.
Yeah, and unfortunately, none of it, you presented no data of patient-centered data, you know, just TLR and patency, which again is, do they live longer, function better, and feel better?
So, and it's again a valid point. However, I did mention the issues of quality of life, and one of the issues when we look at quality of life in PAD studies is the confounder of repeat reintervention. So I tried to make the point, and it's hard to do everything in 4 minutes, but I tried to make the point that in the PTA group, those patients to have the same level of function as the drug-coated balloon or other technology group had upwards of 9 times more repeat revascularization than patients in the other experimental arm. So that's pretty significant to me, because one of the points that I did try to emphasize is what patients want. Patients want minimally invasive procedures. They want procedures that are durable, with no complications, and without repeat revascularization. And I think that's what we're all trying to do with bringing newer endovascular technologies to the floor.
That's very good, because that's my criticism of the primary endpoint in the BEST trial. The secondary endpoint should be the primary endpoint, because by that, what you said is exactly right, because in the way the BEST trial is set up now, that if you do surgery and then redo surgery, it's a failure. If you do a stent or an angioplasty and then redo it every single day for the rest of the patient's life, it's a win. So it's, you know, that's not what patients want.
Well, they didn't say a win for whom.
Yes.
Dr. Lewis.
So I did want to ask the Dukies a question. And this is from a little different perspective, but one of your early slides identifies male gender as a risk factor, and that concerns me in that if you look at your absolute numbers, there are probably more men in the older age groups, but there are a significant number of women. And psychologically and through our experience with coronary disease, if you say that male gender is a risk factor, there can be an under-diagnosis of this in women. I'm particularly concerned because of the increase in diabetes and the fact that this will become progressively a disease of both men and women. And how do we deal with this perception? As you have noted, the outcomes are different. They have higher risk when they have the disease, the women. it really isn't a men's disease, nor is that really a risk factor for some of the worst complications.
Yeah, I think it's a very good point in the slide, which maybe we shouldn't have been so hastily taking from existing sort of dogma, guidelines, information about risk factors. A couple of points with respect to that. As I think everybody in this room knows, there are more women alive than men right now in the United States, and women live probably, we can see, between 2 and 4 years longer than men. And for atherosclerosis not related to the peripheral arterial disease, they present with it. They present on average 5 years later in symptoms, as we've said, that maybe not that we read in the textbook when we learned, and we've learned all these different things. So very much so we want to make sure it's clear that women certainly get PAD. In fact, there are probably more women than men with PAD. Women are disproportionately having amputations, as you've already heard, and women certainly have potentially even different disease sort of burden than men because they're presenting later, much like in the coronary. So I want to dispel any ideas that might have been presented that women don't have PAD, women don't suffer from it, and it's not a risk factor. It may be the age when you're evaluating the patient, potentially. We've thought about it before. So certainly all those points are valid, and we should stand corrected if it was misinterpreted that way.
Thank you. Dr. Zuckerman. Do you have your 10 card up? And then Dr. Do you have another question, Dr. Lawrence? Yeah. Okay, I think Dr. Zuckerman's next, and then you, and then I want to give Dr. Hirsch a chance.
I have a question for Dr. Menard. I was very interested to hear about the study design, and I had some questions about it that struck me as unusual. So I just wanted to make sure I understood it correctly. So I gather there is some kind of randomization in the study, but that within the randomization, each doctor does his or her own thing, I think you said, and that can vary quite a bit, and it's very individualized. And I gather that means it can even be off-label uses of devices which have never been approved for those indications or for those patients. And I guess I have a couple of concerns, one being that the FDA, when they approve devices, usually don't require clinical trials, and so we may actually know very little about the safety, and certainly not about long-term effectiveness of the devices, but you're putting them in a trial where you'll have relatively small numbers of patients getting the same kind of treatment, and that makes it very difficult, I would think, to analyze in a way that would help us understand which treatments are most effective for which kinds of patients, men or women, people of different races, people with different comorbid conditions. So I just wanted to get a better sense of that design.
Yeah, absolutely. I mean, you've highlighted the challenge that we faced and that anyone that's trying to design a large trial faces. I mean, there's two ways to do this. One, you could do what we look on the cardiology world and envy their, huge, well-designed trials where they pick off one specific question at a time, try to answer that question, get a very concise answer. The other way to do it is what we ultimately opted to do, which is to try to be all-inclusive. Clearly, it's a messier way to do it. The limitations are you have a much more heterogeneous data set, and you struggle to make very specific comparisons, which everyone in the room would obviously want. So clearly that was the challenge. What we did not want to do was limit the treatment arm to a particular strategy or particular platform, a la the basal trial, which many of us that treat patients felt was not relevant to our practice by the time the trial was finished. Again, it was 4 years ago. So that was perceived as a bit of a fatal flaw. The NIH supported our pragmatic design and favors that design. The kind of corollary in asking investigators to enter and support a trial that's challenging to enroll and asking them to do things differently than they typically do. Again, that gets to the generalizability of the trial and the results, and ultimately we felt that was going to be too limiting. So
absolutely limitations in the way we've done it. At the end of the day, we felt if we could achieve an appropriate power, hopefully we will be able to answer the questions that we want to answer. But you're absolutely right. Once the patients randomize, the individual investigators can do exactly what they want. Just one more sort of point to that. So our effort to look at, in a critical fashion, new technologies that comes online and decide whether it's appropriate for the trial has been questioned by some. So we've looked at the data for the 2 drug-eluting balloons that have been recently FDA approved and decided to include them in the trial. People say, oh, there's no data on those in the CLI space over a long period of time. You know, why is that appropriate for the trial? But the counter to that is the vast majority of things we do, there's no long-term data for what we're trying to do. So we felt rather than have a trial that at the end of the day that those patients that got treated with those technologies were not allowed, we felt it was better to include them.
Thank you. And I'm sorry, I just have a follow-up about the outcome measures. It seemed, as I recall, the primary outcome measure was amputation-free survival. And are there other outcome measures that are also being looked at?
Yeah, so I guess I was going to make a comment on the earlier critique of the primary endpoint. A lot of thought and discussion went into that and a lot of debate. The primary endpoint is not amputation-free survival. Amputation-free survival is severely flawed for the express point that was made earlier. You do an open or endovascular intervention, and then there's some outcome that's other than death or amputation. There's no accountability for that reintervention or that secondary event. Male-free survival, yes, it's limited to major events. Intervention and amputation-free survival, which is our primary secondary endpoint, also includes minor reinterventions. The 2 clear reasons why we decided not to have that be the primary endpoint was the impact on the patient. So we felt that the major reinterventions have a significant major impact on patients, and the burden was what we were hoping to focus on. And so the minor interventions, yes, are very, very important, but the overall impact on the patient was less. And the second point, perhaps more importantly, is when we use an endovascular first strategy, we presume that there will be more reinterventions. That's an accepted reason to use endovascular therapy, and it did not seem fair to sort of jeopardize or hinder the endovascular arm for that reason. So we are hopefully going to have a very clear ability to make comments on the burden of reinterventions. We recognize the importance of that, but it's just not part of the primary endpoint.
Okay, I'm sorry, I just didn't understand. So what is the primary endpoint?
So the primary endpoint is male-free survival. So it is not amputation-free survival. We're well powered for amputation-free survival, but a major adverse limb event, which was an endpoint somewhat novel. A lot of people are not familiar with it. It came out of the SVS working group on endpoints, and it includes a major amputation and a major reintervention. So a new bypass graft, a thrombolysis or thrombectomy, and a major surgical intervention such as a jump graft. What it does not include is balloon angioplasty, a surgical patch angioplasty. Quite frankly, many of those are day procedures, and the impact of those reinterventions, while very, very important, again, was not felt to represent a big burden to the patient.
Okay, thank you. And I'm sorry, and how long is the longitudinal study?
How long is the study?
Yeah.
Yes, so each patient will have at least 2 years of follow-up, so ultimately 4 years, possibly 5 years.
So, I'm sorry, so the patients could go up to 4 or 5 years, or that's how long it takes to do
the first patient in could have over 4 years of follow-up.
Great, thank you very much. Dr. Lawrence and Dr. Lefebvre, you have another question? Okay, all right, and then I'd like to call an end to this part of the discussion, although if there are burning questions, then we'll proceed. Go ahead.
I had a question for Mike Dake. One of the great concerns is follow-up on my previous question about appropriateness and the potential for overuse. And you presented one of the concerns is that endovascular procedures, although very successful initially, don't have the durability that many, and there's been changes that I know you presented. And you had some excellent long-term data out to 5 years. But what impressed me was you didn't present any physiologic data. You presented TLR, but didn't present what we've been talking about here today, which is ABI, possibly treadmill walking, or post-exercise ABI. So my question is, with those great long-term 5-year results, did you measure ABI? If so, was there a physiologic improvement in your study that would indicate that there is durability, at least if you use a drug-eluting approach as opposed to a non-drug-eluting approach? So it has to do with the role of ABI as a physiologic measure, which has sort of been a standard of care in the field for 20 or 30 years, and why you didn't present it here today.
Thank you, Dr. Lawrence. It's a very good question. And we did measure all those physiologic parameters at regular intervals yearly. One of the problems with the trial design was that when someone came in symptomatic, they weren't repeated prior to the intervention. And so consequently, by sampling only at regular interval times annually, you mask any of the real benefits. Now, if we censor all those people who basically had a reintervention, of course, you're going to show a benefit. But it's a somewhat limitation of the trial design for that particular trial, that obviously all of the things weren't captured prior to the intervention. And if that were the case, then that would be able to do that evaluation. Does that make sense? Or?
Yeah, so do you believe that ABI should be a standard as a physiologic test for all the interventions that we're talking about today?
Yes.
Great. Dr. Lefebvre. Yeah, my question was on the evidence for key question 3 is for Dr. Patel and Jones again, although I think some other people might want to weigh in. So you reviewed the evidence on critical limb ischemia in terms of the comparative efficacy of endovascular versus surgical treatments. And I would have thought that was the correct framing, because I think you have the starting point that you have to do something in those situations. You can't do nothing. But then we heard other evidence that came out later. People pointed to the fact that amputations were reduced, correlated with procedures, and there's a correlation between workup for PAD and reduced amputations. So my question is, when you did your evidence review, did you review evidence of interventions versus no interventions for critical limb ischemia, or did you think that was just not a relevant question? You didn't even look at it, or did you review the evidence and there wasn't any evidence that met your criteria?
Thanks for the question. We did review for all studies, and the way the literature search was constructed was to put in every intervention, every comparator, the patient population, and the outcomes. And whatever came out was then filtered and put into buckets. Well, they fell into these buckets. However, only 4 looked at endovascular versus surgical. Endovascular versus usual care. Remember that surgical versus usual care had been done, but it was done before 1995, which is when our study started. So that didn't actually meet entry into our study. And so of those 4, none were good quality studies, because the good quality studies ended up being the endovascular versus usual care. So we looked at them. We could not do a quantitative meta-analysis on those studies. And that's why we really chose to focus on endovascular versus
basically
surgical.
no evidence on intervention versus no intervention in critical limb.
Very little that we could find. And of course, all the patients that you saw somebody had to feel comfortable that they could get revascularization, and most of the guidelines during this time period are saying do some sort of revascularization.
Any other questions? Great. Okay, at this point, thank you, speakers, and we're going to have an open panel discussion along these lines. And I did want, Dr. Hirsch, I had cut you off earlier. This might be, if you had something you wanted to say that was related to this earlier conversation, we'd love to hear it. I don't want to put you on the spot, though. And please also tent cards or just interrupt each other. I don't really care.
I always need your guidance, Peter. I always have something to say, but it's hard to know where to focus. First of all, to all the presenters, great job, and to the panel, the goal is to assist you in Medicare. I have two general domains, and tell me if this needs to take 3 minutes or 6 minutes. The first is the PAD burden is obviously gigantic, and if I were a CMS beneficiary, I want to look for the sweet spot where the evidence overlaps with efficacy and cost effectiveness. So for the moment, I'm going to ignore the asymptomatic population where hopefully risk reduction therapy will be given. And for the moment, I'm going to ignore the 100 to 300,000 ischemic amputations for which my heart breaks every day. And look at the 1 to 3 million Americans, most of them are Medicare beneficiaries that have claudication. What I didn't hear today, I was going to address this to our Dukites, but is whether we really know that there's a relationship between ankle pressure, patency, and patient-focused symptoms, as Dr. Swain said. In other words, there's a question coming, if I know that medication works, because there's over 2,000 patients in placebo-controlled trials with no change in ankle pressure, and if I know that supervised exercise works, I think, Dr. Jones, you showed that in your report. How important really is patency anyway to the average Medicare beneficiary with claudication? My question is, in America at the current time, what fraction of beneficiaries do receive a claudication medication, an exercise program, or an endovascular approach? I think we know that. The panel and the audience might want to know.
I assume you're asking us.
Yes.
Since you said Dukites.
I did, the Dukites.
We prefer national champion Dukies.
And I love your championships.
Either way.
Minnesotans love what you're doing. It's okay.
So, Dr. Hirsch, when we look at various data sets, and you've looked at them as well as we have, there are upcoming areas of study, some of which we've both been involved in, that can answer some of these questions. From a CMS or Medicare standpoint, from what we've looked at, I would say that it's unable to be determined what percentage of patients get supervised exercise. I would guess that it's near zero.
That's a good guess.
Near zero. Depends on how you define it, and depends on where it is. Now, for cilostazol and pentoxifylline, specifically as disease-modifying agents, per se, it looks like about 10% of patients get those medications sometime surrounding a vascular intervention. Does that answer your question?
Manesh?
I guess the only other question you were hinting to was the relationship between hemodynamics, patency, and symptoms.
Yes, that's important. Physiology is important in understanding the results of all of these trials.
That's right. So there are relationships in individual trials. The meta-analysis of HRQ work you saw we presented did not look to investigate how direct that relationship is. We all know from several of the presentations that is not a direct one-to-one relationship. There is a relationship, but from what we've seen, it's not a direct one-to-one. We did not do a systematic analysis of the physiology to the patency to the symptoms.
Thank you. I have one follow-up question, because I do care about claudication, but I also care about the many hundreds of thousands of ischemic amputations. I love the speaker who said that there are more amputations from PAD than there are from, many ways of saying it, landmines in the world, trauma, motorcycle accidents, than anything. There was a relationship discussed, I'm not sure I'm addressing this to you, that amputations have decreased in the country, an implication that this is because of endovascular therapy, which may very well be the case. Straight line flow is important, my patients get that. But I think as an epidemiologist, and as we think about this from a CMS perspective, are there other variables that could lead to the decrease, if it really exists in the amputation rate, like the temporal decrease between 50 to 25%, in Minnesota 12% of current smoking, or the temporal concomitant increase of use of aspirin, other antithrombotic agents that has about doubled over the last 10 years, again in the same population. Or again, the use of statins, in adults has gone from near zero to nearly 60, 70%. So the question I guess I'm asking is, do we really know about the causality of the temporal trend of the decrease? Because there's temporal trends and decrease of all of the ischemic outcomes of all of the atherosclerotic diseases. Anybody wants to take that? Dr. Patel?
Yeah, well, let me pile on. I looked at some of these graphs and I saw what appeared to be the slope in the reduction in cardiovascular mortality, which is unlikely due to peripheral endovascular intervention.
Yeah, and they started before a lot of these interventions.
Okay. So I think there are some important questions, and we showed one slide, and others are welcome to comment on it. We showed one slide of just temporal trends. Of course, that's always tempting, but there is no causality information there, as you know. What we would say is there are multiple confounders, as you stated, other known things that affect cardiovascular mortality and probably patient outcomes, such as risk factor modification, smoking, statin, antiplatelet agents. The antiplatelet agents, we gave you some evidence that we showed on what the effectiveness of that is. Second, of course, though, which we didn't show you, is that the population's aging, the burden of disease is going up, the rates of diabetes are going up. So certainly the number of patients in the country that are at risk for any one of these may also be changing at a rate that we didn't quantify. So we can't speak to either, except to say that there are probably confounders on both sides.
We're here to define knowledge gaps. I just want to make sure the gaps are well known, and the non-gaps, for example, the supervised exercise signal is also well known. Separate the gaps from the knowledge.
Okay, great. So we can use this time to ask speakers. Oh, sorry, go ahead. Saved by the bell.
Okay, so for purposes of discussion, which keep us within the FACA rules, I'd like to express some discomfort I have with the wording of the questions and then make sure that we're all answering the same questions when we vote. So for instance, for number 1, for adults with asymptomatic lower extremity PAD, how confident are you that there is sufficient evidence for an intervention that improves A, intermediate, near-term health outcomes, and B, long-term health outcomes? Well, if I knew what outcomes we were talking about and that we agreed on, I would have a lot better chance of answering that consistently with everybody else here. So I guess my question is, are these outcomes related to the extremity, or are they total cardiovascular outcomes? That's question number 1. And then the interventions, there's just a wide array of potential interventions here. I mean, if I really took a broad view of this question, I'd say, sure. I mean, yes, I have high confidence that there's lots of interventions that it could increase lots of outcomes in this group. But that's true about everybody in America, whether they have PAD or not. And so I'd like to narrow the questions down as a panel, if we could, and get to specific outcomes. That would help a lot. Then the interventions, we can go from there.
Can I just add to that question? Because I think, first of all, I just want to clarify that it says, do you believe that there's interventions that are effective? First of all, I mean, I assume it's saying, do we believe the evidence demonstrates that? I mean, you don't want us to bring in our personal beliefs about exercise or things like that, correct? I mean, that's the first thing, right?
Yeah, it's confidence, not belief. They're saying how confident.
Confidence, but I might be confident exercise works, but it might not be based on this evidence. So I assume we're voting on this evidence. Is that correct to say?
I think that's an excellent set of guideposts, is that this is an evidence development coverage advisory committee, so the responses should emanate from interpretation of the evidence.
Right, okay, and then that's the easy question. The harder one, I think, is I think the comparisons and what we're comparing it to. So again, I think that the question is, when we say, do you have confidence for efficacy of an intervention, is that efficacy in an absolute term, or is that comparative efficacy? And I think question 3 demonstrates that the best. I mean, I would say you might say that you're confident that surgery leads to improved outcomes, but you're not at all confident that the comparative efficacy of surgery versus endovascular has any good evidence. So I think that's really a sticking point to me about how we're going to vote on these. Are we voting just in isolation for each of these technologies, or are we voting on comparative effectiveness? Because most of the evidence presented was comparative effectiveness, especially for questions 2 and 3. It was mostly comparative effectiveness, but then the question's not structured that way, so I'm not really sure what I'm answering that way.
I think that one, I'm going to do my best with that one. That one's actually easier for me to answer. The issue is, in general terms, against no intervention, even if we don't have high-quality evidence for that, right? And remember, and there was some tussle over this or in the ACA about whether or not comparative effectiveness could even be part of coverage decisions. I think the general tenor of the law is against that. But we're not here to make a coverage decision, simply to give a view of the landscape. And so I would think, even if we're looking only at, head-to-head of intervention versus intervention, the nested notion is against a comparator of no intervention. Because the question is, do we pay for X, or should the government pay for X compared to not? It's not so, if you will, it's a latent variable.
So,
Marcel.
So I want to comment on the question about question 1. I think if the person is asymptomatic, your health outcomes are mostly bad. So, I mean, in terms of what you're interested in, they have no symptoms. You can't improve their symptoms, right? Because they have none. So all your outcomes would be then, I think, in the area of you can get harms from interventions, you can prevent death later, right? I do not think that the other outcomes that CMS listed in their slide of what outcomes are of interest to CMS at the very beginning come into play for the asymptomatic person. So second point on this question, time frame, I guess, for intermediate versus long term, it doesn't matter, but I think I have a general ballpark I use. But there are similar points for the asymptomatic. Finally, this question is focused on asymptomatic but has peripheral artery disease. So based on some criteria, they have peripheral artery disease. I don't want to get into, for me, this question of what else they might have. So they may well have a lot of other things, and there may be a lot of lifestyle interventions that can prevent disease in those people, but we're focused on the peripheral artery disease interventions. So to me, this is not as hard of a question as you make it out to be. Hopefully that would clarify a bit.
Thank you, Dr. Saliv. Dr. Leister, I'm going to get to you in a second here, but I want to circle back. Dr. Carr made a point about the AHA guidelines, which I wasn't immediately familiar with, but I got the implication. Let me restate it. Is there a way to look at this first question that proposes that the discovery of PAD through a series of actions which alters cholesterol, actions taken against a person's systemic cholesterol levels, alters their outcomes? So it's actually not treatment of the PAD, it's essentially PAD as marker. And I'm throwing that out there. I feel quite naive in this clinical space, but I'm just trying to hear what I...
Okay, one last comment from me. So the coverage program in Medicare doesn't deal a lot with pills. So I don't think we have to focus on pills in this discussion. I believe there was a Cochrane review that talked about lipid lowering in PAD that was very positive.
Yes.
And it wasn't yet mentioned, I guess, either, but was circulated to the panel. And so, I believe that intervention is quite good for PAD patients, lipid lowering. But so we could say, yes, we believe that's the intervention, and that's another easy way to answer this question, but it doesn't help the coverage program too much, I guess.
Dr. Leistig is next, and then Dr. Hirsch, who's got a quizzical look on his face.
Thanks. So I was responding in part to the comments you made about the comparative effectiveness. So to the extent that we should be reviewing essentially how well a particular therapy works versus how it works in comparison to something else.
Can you speak closer to the mic, please?
Sure. All right. So with the comparative effectiveness, it also brings up the related issue about using data from registries, and to the extent to which also we should be basing our conclusions upon other types of non-randomized trial comparisons and observational data. Several speakers had pointed out the interest in what might be done, for instance, with the Vascular Quality Initiative. But if one were to take the approach that registries would be a desired mechanism to get additional data, and yet in the sponsored reviews that we are to see from ARC, for example, that reviews the available evidence, and those questions are set up in the screening process where such registry data would be structurally removed from consideration as valid evidence, it seems hard to say how that could be effective. We are moving towards a state where we are trying to find better mechanisms to synthesize evidence from a variety of sources. Obviously, a well-run randomized clinical trial is a great source of evidence, but randomization as a mechanism for treatment assignment is a pretty poor proxy for overall quality of a study. It's often the case that there's high quality for randomized clinical trial, but it's not the case that only randomized clinical trials can provide strong evidence. So if we're thinking about scenarios where we're trying to understand what available evidence exists for multiple therapies to inform our judgment, we should consider not only how it is that we would fairly evaluate the contributions from registries, but also to move into saying, in single-arm studies, in other observational mechanisms, what are approaches we could take that would allow us to synthesize this evidence fairly so that we can make these better conclusions about the effectiveness of the therapies. And I think that general concept about making more use of available information, both currently existing and as existing in the future, will very much inform how we can make these types of assessments.
Thank you. Who's next? I missed which of you guys. Dr. Swain, are you next, or is Dr. Salib next?
One quick question, then a second question. For the center, give me your definition of long-term. Is it 2 years, 5 years? My general definition, even though it's not long-term, is 5. But
so let me take a crack at that. I certainly don't speak for the agency, and correct me if I'm wrong, but I think to some extent it's bespoke to the clinical situation, and if I'm looking at some of these overall survival curves in this population, I think what we'd often think of as long-term for preventive interventions isn't appropriate, and I would say sort of after the period where the potentially adverse effects of the intervention have sort of cleared, then you'd probably be in a longer term. I'd say after 6 months. 6 months seems to be an early time point in some of these trials that would constitute maybe the beginning of a long-term window, maybe a year. These looked like populations of patients who had very fairly brief average survival. So I think saying looking at a 5-year outcome when there's a large number of deaths prior to that is made.
CLI, for sure, relevance. For CLI, that's a for sure. For claudication that occurs, on the 17th hole when you're carrying your bags is probably 5 years. So just a difficult question the way it's asked. And I guess the general comment from today is appreciate all the speakers to review all the literature is, as a cardiovascular surgeon, it's embarrassing that we haven't done better. And as a former FDA person, it's embarrassing that more data, better data wasn't required before approving devices. So we can see that the world's changing now, and there's great studies upcoming, of which we don't have the answers yet. They haven't been published and able to be peer-reviewed or FDA committee or whatever. So I think that in the future we will have data, and the registry, I think, can be important. It's only a recent registry. There's only 100,000 peripheral vascular so far. But, to beef up that registry, to make it required, and there's incentives, just like in cardiac surgery. You don't get paid by insurance companies unless you're in the STS. That may well be useful in the future for propensity scoring of studies and using as a historical control, like we use some of the UNOS database or the Intermax database and things like that. So I think that, we have things coming, but right now the lack of data is just impressive and very disappointing. But I think future, and the idea that we have these 6 randomized studies that were listed by Dr. Turco, and when the PARC committee, started in 2011, you've just got to have common definitions and common endpoints in order to be able to compare anything, and can appreciate the problems that our Duke friends have doing these comparisons, because it's where cardiac valve disease was 30 years ago. Everybody did everything differently. So I think CMS has a problem right now of using evidence-based medicine, because there's very little good evidence of not only comparison to comparison. It's kind of like saying in my family, we could compare who can dunk a basketball best, but that doesn't really, we need to be able to compare in a lot of these things of an intervention versus things like exercise. And we just don't have any of that data. And I don't know that we're ever going to get any of that data now, because kind of the horse is out of the barn. So I appreciate the problem that CMS has had.
I'm sure our colleagues from Duke appreciate the basketball metaphor as well. Dr. Hirsch, did you have a comment?
Yeah. I made a comment earlier about claudication, one about CLI. I want to come back to the asymptomatic cohort, and having participated in the ACC-AHA guidelines twice over, maybe I can provide some insight for the panel members. This term asymptomatic is extremely problematic and probably should be discarded. There's other evidence not presented today that suggests, as one of our public speakers said, that no one is truly asymptomatic. If you have an ABI of 0.85 and you've stopped walking and you don't speak English, you don't complain as well, you have a functional limitation. That's the work from Mary McDermott at Northwestern, multiply published in multiple sources. The challenge is if we wait again in the post-ACA world where we're not RVU-based and we're trying to keep the Medicare population healthy, if we wait for people to complain in English language in a way we understand, we only detect 1 out of 10 or actually 1 out of 20 patients with PAD. So when the AHA guideline was written, the thought was that, again, in all of the trials that have existed, we don't really use the term asymptomatic very often. If my colleague here had a previous leg intervention 20 years ago, but no longer complains because the intervention was successful, he still has very severe PAD, despite the previous success. Or if my next colleague has PAD with the same ABI, but again has stopped walking, his event rate is not driven by his risk factors, the question earlier. It's no longer 1 or 2% per 10 years. It's now at least 4 to 5%, probably 6 to 8% in the community population. So the time frame of risk is as short or shorter than a patient discharged with a STEMI. In other words, the PAD diagnosis in the asymptomatic patient unmasks the functional limitation, unmasks the cardiovascular risk, and although we don't have a primary USPSTF A grade, that's true, we don't have a prospective single randomized trial, that's a knowledge gap. I could probably reference 5 additional studies, the old Capri study, the current TRA2P study, the previous Ramipil trials and heart protection study with statins and ACE inhibitors, whereby within 1 year, those coronary event rates decline by a lot, 15 to 20%, and an absolute risk reduction in the first year of 1%. And these drops in rates are short-term, meaning the first 6 months to 1 year, the definitions, and never go away. They persist. So I just want us to caution ourselves that, not to be too cynical, as Dr. Beckman is no longer here, that there probably is no such thing as asymptomatic. Final one, knowledge gap. Of the critical ischemia patients that actually present in our country, fully half of the presentations are first CLI. They're not stages of disease. So you're asymptomatic today, and tomorrow your first presentation is a black toe. So there is the opportunity to provide surveillance and earlier detection if we detect, quote, asymptomatic PAD. In other words, you, Peter, might have a 1 centimeter lung nodule but not be coughing yet. We have to be careful. Unlike lung cancer with microscopic lesions, here we do have therapies that actually are fairly well proven to change the natural history. I hope that's helpful.
Dr. Deo?
I guess those comments confuse me a little further, actually, rather than helping me.
Why?
If there's no such thing as asymptomatic, then I assume that everybody in this room who's had a leg symptom is potentially got PAD.
Well, no. I mean, it's like everybody with chest pain doesn't have coronary disease. The goal is to detect the ischemic symptom and accurately define it by a diagnostic test.
I guess an underlying concern that I have here is that in other areas of medicine, we're learning more and more that screening in general populations may not have the benefits that we really think it does, in part because there are adverse consequences to screening itself, even in non-sick patients. And in the absence of a clinical trial, for example, demonstrating the benefit of a screening strategy, I guess I'd be reluctant to endorse a screening strategy. And it seems to me that's in part what underlies this question about treating asymptomatic patients.
You're right on the money. We have to be very careful about the term screening. Without a prospective randomized trial, it's a knowledge gap. We can't have confidence that the benefits are always greater than the harm and are cost effective.
I think, let me rephrase, Dr. Hirsch, what you said. I don't think Dr. Hirsch, I think he was saying asymptomatic was a problematic moniker because of all the stuff we assume it means about the patient, but then you were listing actual changes in behavior, functional status, things like that, that we as clinicians may not be particularly skilled at picking up, or if we do find them, we don't naturally reflex to logical explanations like PAD. I think that's what you're saying, as opposed to, and Rick characterized it as, any leg symptom, but I think it probably there's somewhere between these two things is what you intended to say, not any legs. If you stub your toe, that's not mean you should be screened for PAD.
Absolutely correct. I have tremendous respect for the evidence-based process of USPSTF. We don't have prospective level 1 data, true level 1 data with a control group with long enough follow-up to know about benefit versus harm. However, we should have caution that we don't discard the asymptomatic group entirely, because there are interventions that if you were in my office and you had an abnormal pulse but you felt fine, and your ABI is 0.5 but you felt fine, you could be maintained in health with Medicare-based medical interventions that are known to be effective.
I just have to correct an implication that the USPSTF only accepts randomized controlled trials as high-level evidence. Entirely not true. They have a process where they do look at observational studies. Observational studies can be upgraded because of quality, consistency of results, magnitude of effect, and so forth. It does not require randomized controlled trial to get an A or B rating from the USPSTF. And the rating when it comes to screening using ABI for peripheral artery disease is an I, which is insufficient evidence, which I think is where we're at. So I don't think we really have a disagreement with the USPSTF on this particular point.
Yeah, and I think their review that was provided to us was positive on the ABI for detection. It did reflect that the intervention needed to be proven to be beneficial after that. And so I think that there was definitely a path there forward to something that might be useful. And I don't know that we need to endorse or disendorse that. I think it's a reasonable approach that they said. And hopefully there will be some intervention that could be used, that could eventually.
Dr. Sujay.
Yeah, not a question as much as a comment related to, not so much a question, but just a comment related to the evidence. And there's some data. Most people don't have just one risk factor for PAD or CVD. And there's some evidence in trials going back to, if you know that you have one risk factor, or 2 risk factors and 3 risk factors for diabetes, for example. And since we're basically economic beings, if you're going to invest the time and energy to manage your diabetes, you're not going to ignore your hypertension or your smoking or your other stuff. So it's not really an answer, but since you mentioned we're going from an RVU-based to an outcome-based medical encounter, my comments don't really help us answer these particular questions, but it's just a general framework about how patients will modify and invest, even older patients whose marginal return on investment in terms of their health outcomes will be less than 30 years before. But it's not a factor that should be underestimated in what patients do to commit to maintain a good outcome.
Dr. Kormos.
So I may unmask my naivety in this field, but in my world, there are very few 510K devices. Everything's a clinical trial. I'm trying to understand, I guess, as we decide about whether interventions make a difference. The word I heard in a lot of the presentations today was heterogeneity. And there's a lot of heterogeneity, both in the disease, the presentation, the patient populations. And today I heard that, in fact, how these devices are used are very heterogeneous. There's all sorts of different methodologies and strategies for implication. And that's where I get a little bit fuzzy about how definite I can be in how I'm going to try to answer these questions. Because, is one 510K device the same as the other? When was the predicate device laid down? How long ago? How much are we following the same path? But the devices have really changed now. And so at what point do you say, okay, it's time to really do a full clinical trial? I don't know. And so when you ask me to you know, what's the evidence that I mean, some of these I think I got a handle on. There are interventions that clearly help. But as I get into the more esoteric device area, then I'm having a little more trouble understanding how to make that interpretation, giving the variety of devices, how they're used, and the variety of the disease states. That's where I'm struggling. And I don't think there's an answer, it's just a comment.
Dr. Lefebvre.
I just want to make a comment about the issue of RCTs and registries, because I think there was a lot of comments made here. And I think I'm certainly in favor of registries, and I think the presentation by Dr. Cronowart was very good in terms of what registries can do and what they can't do. But I think sometimes we go beyond what registries can do, and we expect to be able to get treatment effect information from registries. And I think there's only very few situations where you actually can get treatment efficacy, comparative effectiveness of treatments from registries. And those are when you have relatively unconfounded interventions in a homogeneous population. Here we have very much the opposite. We have heterogeneous populations with very highly confounded outcomes. Whenever you have cardiovascular disease, there's very highly confounded outcomes. So I think we absolutely need to insist on RCTs for the primary questions. For the issues of intervention versus medical therapy, for example, we need to insist on RCTs for those questions. And if we try to get by with lesser data, registry data, we'll end up 10 years or 20 years in the same situation we are now. We won't know. We won't be able to answer the question. We'll have some suggestive data. We won't be able to answer it. So I think we have to be very clear about what kind of studies we need, where we need RCTs, and what registries can do, but not to mix those, and be very clear where the RCTs are needed and what questions cannot be answered by registries.
Thank you. Dr. Leistig, did you have something else? Go.
Yeah, so it actually comes back to this most recent comment again with respect to the registries issue. So first off, to the prior comment, I agree that there are mechanisms out there that exist, primarily in many journals, about how you can view observational studies as being equivalent to, or at least the same level as a randomized clinical trial. My point that I was trying to make earlier was simply that if there's interest from CMS in the use of registry data to make informed decisions in a panel such as this, then there seems to be a problem between having a commission review that has as part of its requirements that the data to be summarized has to be a randomized clinical trial. So you're structurally throwing away that information from saying that, okay, how could we learn from the registries? And to this most recent point about what we can learn from the registries, again, I think there are many endpoints that we are interested in. And for things such as quality of life, that sometimes can be something that is easier to get out of a registry framework, provided that the analysis plan is done appropriately and steps are taken to try to find subsets of the population where you can find homogeneity and you can get rid of some of that underlying heterogeneity. So there are scenarios where it is almost a requirement to have randomized clinical trials. I'm not gainsaying that. I'm just saying that if we also want to make the most use of information that is being generated, we should consider avenues that would allow that non-randomized trial information to be incorporated in these types of deliberations.
Great. Thank you. Dr. Lefebvre, your card is still up. Dr. Kormos, your card is still up. I don't know if you have more to say. This is very stimulating discussion. I appreciate the panel members sort of prompting or pushing each other to be clear on their points. We're going to take a break, but before we do that, when we come back from the break, I'm going to ask you to vote. So I'd actually like the panel to take a moment before we break and think carefully if you feel like you have the bounds of the questions adequately defined or whatever, so that we can go through a voting process and a discussion around our questions. And if not, Dr. Carr.
Just quick point of information. So on question 1, long-term health outcomes would be cardiovascular death, coronary heart disease death, cerebrovascular events. Those are the long-term health outcomes we would be voting on.
Well, so on the voting sheet, there's a list of the clinical outcomes of interest is the second half of the third paragraph on this in your packet. And it lists a set of outcomes which includes the ones you just listed as well as a number of others. I can just read them. Reduction in pain, avoidance of amputation, improvement in quality of life and or functional capacity, including walking distance, wound healing, avoidance of cardiovascular events, these are the ones you listed, MI, stroke, cardiovascular death, and all-cause mortality, and avoidance of harm from interventions. So that's a sort of market basket of outcomes.
I mean, there was some discussion among us to limit the scope of that question to just peripheral vascular disease outcomes, but our mandate clearly includes cardiovascular events, death, cerebrovascular accidents. So when I'm voting according to the instructions on the sheet, and we really presented very little to no evidence on prevention of those outcomes for asymptomatic people, but there is a robust literature in that area that would indicate that peripheral arterial disease is a CVD equivalent, much akin to diabetes, and that we have prevention strategies that are highly effective.
So I understand the question. I'm just doing the best I can as well. But the first level question allows for a range of responses, which my read of it would be you would express a level of confidence you have for the highest effect intervention on the highest outcome, because the subsidiary questions or the follow-on discussion allows us to then bifurcate or trifurcate the space with the discussion. If intermediate confidence on one of these interventions in your head, please identify the specific interventions and associated outcomes. So that gives you the discussion around each of the questions, 1, 2, and 3, where it allows you to segregate those things. Okay, well, I'm talking about CV events or cardiac events or peripheral events, and these are the events I'm talking about. I hope that helps. And then beneath that, there's a question in each of the, there's a sub-discussion in each of the questions saying, considering the heterogeneity of the Medicare population, discuss which subgroups of the population the evidence shows are likely to benefit or likely to not benefit from that intervention.
So, I mean, just point of information, we really have 6 voting questions as I look at the green sheet, right? So we're going to rate for questions 1, 2, and 3 an A and B on each question. That's just the point of information. Are we?
Yes, that's right.
Okay.
Right. I believe we're voting 6 times.
So
right?
there's 6 questions.
Immediate near term, 1 long term,
and
2, et cetera.
And each one of those has the outcomes that are in the instructions.
That's right. And then after each one, there's a discussion about, okay, well, which outcomes? Okay, which interventions? I hope that helps.
Right. I'm just making sure that we didn't change the instructions when we vote, when we come back.
No, the only thing we're not allowed to change is this piece of paper.
Okay.
Please.
It seemed that there's some differences of opinion about long-term data and what that means, and also obviously that long-term is different for the different groups, and certainly I was not comfortable with the idea of looking just at long-term data regarding what happens immediately after the intervention, because because if the intervention is successful for a short period of time and then not successful, that's important too. So I don't know if that can be clarified by CMS, or if you don't want to clarify it, or I'm just trying to get a better sense of what we're talking about.
Yeah, that's right. I agree. Yeah. What I would propose, I don't think it's particularly productive if each of you voting has a different definition. I don't know if we could easily converge on one, but I propose we try right now to try and separate those 2 questions for us collectively, and then CMS will take, within the context of the definition we arrive at, the answers we've given them. Yes, okay. So, floor is open. The difficult distinction between short and long-term outcomes.
I think for number 3, the short-term outcome being wound healing. Wound healing.
Wound healing.
With knowing that sometimes these things can fail at 8 months or 12 months, that would be long-term if the wound had... If the wound had healed in the interim, that still might be a positive short-term outcome.
So can you put a time frame around that?
Well, I guess 6 months for wound healing.
I'm totally comfortable with choosing a different break point
Yeah,
for each
well,
of the three questions also. I mean, I think within reason, does that solve our problem? And I'm just trying to get to a structure here where we
that's why
can
I
vote.
started at 3. It just seems like it would
took
be
the
very
easy one.
different from 1. Well, 1 is almost easy in its own way too, because long-term outcomes would be the cardiovascular events, and those start maybe 2 to 5 years.
Okay, so I think proposal on the table very loosely is a 6-month cutoff for critical limb ischemia between short, intermediate versus long-term. Are people comfortable with that? It's not,
I mean, just give a number, people can choose a different number.
in the critical limb ischemia, question number 3, we're going to use 6 months as a break point between.
It's hard to know, Peter, what time frame is appropriate. Let me just give an alternate perspective, but I don't know the answer. If we were the patient, not the trialist, not the company, not me, when I get an intervention at a doctor's office, I'd like it to work, I'm just going to say out loud, for at least a year. I don't want to be coming back every 3 to 6 months. And if I were thinking long term, what I want my wife or my best friend to have, it'd be 5 years. Of course, the reality for PAD is we don't have any outcomes generally beyond 1 year or 2 years for almost anything. But we could take all 3 questions and, I hate to say it, kind of merge them. All we really have is 1 year data for most everything. For question 3, even for wounds, even if they heal at 3 or 6 months, we all know they recycle and reopen and then reclose and then reopen. So in our trials, it's very hard to pick a time point that makes sense. So for the panel, you could choose 1 and 3, 1 and 5, but be careful if it's anything much shorter, because I don't think patients necessarily value that. Years. Durability is important. So I'm advocating for longer time frames.
So
good for
the
patients.
counter proposal, I'm just trying to triangulate on something here. Counter proposal is a 1 year, short-term outcomes mean outcomes out to a year. And then there's a separate thing, which I think is largely constrained by trial design and follow-up, which is 5 years arbitrarily, meaning gives us a view into the long-term durability. People comfortable with that? That's across all 3 questions now.
But it's
1 and 5.
I think it's just so different. In group 1, you may be talking about a 40-year-old has an ABI of 0.9 or something.
Understood.
And so aspirin is an intervention. You'd really want to know 5 to 10-year data. Whereas in the second one, in intermittent claudication, which could be, again, not able to walk across this room, versus the other end of the spectrum is claudication when you're carrying your bag of golf clubs on the 17th hole. So you've got a huge thing. So I would propose like 5 years for that as long-term, if you're going to study device or drugs or whatever. And then for the, horrible limbs, the CLIs, 1 to 2 years is long-term, and then intermediate maybe 6 months to a year, and acute is less than that.
Does anyone have a view? I mean, I think the first decision we're making now is if we're going to use common standards for all 3 questions, or if we want it to be a sort of a moving cut point. And I'm not hearing a clear consensus. And
There are 3 different populations. I think there should be a moving cut point.
I agree.
I'm seeing nodding heads. We're not going to vote on this. Is there some articulate difference of opinion around that, or we're going to use a moving cut point?
I think the question 3 is a different one immediate outcome. Question 1 and 2 to me certainly have, I think, the short, intermediate, and long. And I would agree, Dr. Hirsch. I've seen like less than 1 year short, 1 to 5 years intermediate, and greater than 5 years long. I think that's a general standard. But I think here we should just make it simple and say 1 year and less or greater than 1 year. Because we say immediate, near term, and then long term. So we don't really have an intermediate. We don't have an intermediate step. So I would just say make it simple, 1 year and over 1 year.
Okay, so proposal on the table is up for question 1 up to 1 year, up to 5 years for the immediate/near term versus long term. Are there objections to that?
What was that again, 1 year and 5?
1 year and 5 years. We haven't talked a lot about the intermittent claudication. Let's go to question 3 to resolve that. Are we comfortable with 1 year and 5 years, or do we want to talk about 6 months and 2 years or something?
I guess I'm uncomfortable with 1 year because the data don't support that people do that, even live much longer than that.
Okay, so 6
and
months
they
and...
have pain control
Yep.
immediately, which would be a good outcome for many people. So is it what I want? No, but is it what happens?
Yeah, well, I think the important dichotomy is actually separating the research into its appropriate buckets as well as the sort of clinical experience of the patients. I'm throwing out a number here. I don't have a preference. 6 months and 2 years for question 3?
Sounds good.
Sorry. 6 months and 2 years. 6 months and 2 years for question 3. And then for the one that's between, the intermittent claudication group, is this also a 1 year and 5 year, or is there some other?
Sounds good.
Dr. Leistig?
So, the proposal I heard before sounded like it was saying that we should consider this not in terms of average of 1 year and average of 5 year, but with a 1 and 5 split, but rather things less than 1 year and things greater than 1 year. So I'm confused.
That's what I was saying on questions 1 and 2, yes. That's
yeah,
what I was suggesting.
that seemed more sense to me, but that's what I thought with the
Okay, so, all right. Can you re-articulate that in a statistical sense so that we can all know what you're saying? Or what the distinction is?
Less than or equal to 12 months versus greater than 12 months, and have that be short-term versus long-term, because you're just splitting the space up into 2 adjacent areas, as opposed to targeting things targeting things just at 1 area versus targeting things just at 5 years. Say there's 2 spaces, and the questions are set up in terms of essentially an endpoint for a therapy for which you have the most evidence. And it's just where that time point falls in within that dichotomy.
All right, so those are outcomes. All right, so I'm trying to make sure I have this distinction clear. So we're not talking about experiencing, for example, outcome improvement through 1 year as the short term, by continuing to experience that outcome up to 365 days versus up to 5 years. You're talking about experiencing improvement in outcome within the 0 to 1 time interval, but that could decay, and that would still qualify as a short-term health benefit. But then having the continued experience between 1 year and 5 years would count as the long-term.
That being said, for many of the outcomes that are like survival analysis, you're effectively making your inference based upon 12 months, which is a function of what had happened up until 12 months.
Agreed.
So effectively just saying the information available within the first 365 days versus the information available past that time point.
Okay. I understand what you said. Is there comfort on the panel about that?
No.
Yes.
No, I mean, I just want to say, we certainly don't want a study that's 2 days long. I understand that not every study is going to be up to a year, but I don't think we can just say anything up to a year is short-term benefit, because a 1 week study is, I think, too weak to be a benefit.
We're not talking about a 1 week study for any of this.
All right. So the distinction on the table, speaking just about the short-term outcomes, just to make sure we're clear, is the distinction between, is a short-term benefit, can it occur before the end of a year and, for example, disappear and it still counts? Or alternatively, does it have to be durable to 365 days to count? I think, Ted, is that the distinction you're making? I think it is.
My distinction had to do with just trying to split the time scale into 2 adjacent regions, right? So things happening up to a year, things happening after a year. And again, the way I'm reading the question, maybe I'm reading it incorrectly, was that how confident are you that there exists a therapy for which there's sufficient evidence for immediate near-term health outcomes? So it's the best evidence for some therapy in one of these 3 areas in a particular time interval. So it's not to say on average across all therapies for all outcomes, it's what's the outcome with the best evidence.
I mean, again, you're comparing the third question to the first question, and the idea that a 13-month evidence of something for 13 months in an asymptomatic PAD patient doesn't, I could never use the word long-term for that. So I don't know what the solution to this one is other than we qualitatively define it when we vote on it, what we mean by it, and CMS can look at the transcript, which we know you'll do.
I don't see why it has to be adjacent. I don't see the benefit. Also, just want to say that even if you had a 5-year study and not everybody lives to 5 years, that doesn't mean it's not worth looking for as long as you can look. for those patients who live longer.
Okay. We've done more sophisticated interpretation of the document in front of us. Short term is the, we're going to go, if this works for you and everyone, with Dr. Leistig's definition, which is during the time interval up to, for example, a year, there is an intervention that alters health outcomes. But the second question, long term, has a reasonable time point of durability. Call it 3 years, 4 years, 5 years, something like that. We're limited by data on that. But so if you're sort of, the cartoon version of this is if you have an intervention at 364 days, you're doing fabulous, that's short term. If you have it, you're doing fabulous as day 367, and 368 you're not, you don't cross into the, you haven't satisfied the long-term benefit. You have to be at 5 years. Or I think we acknowledge that data run out before we would like, and so off of, in the projection across the time horizon. Does that work for everyone? That distinction. So if you will, there's a large donut hole between those two endpoints.
So just so I know, so if it's 366 days for an intervention, that would be a successful short term?
That's right.
Okay.
Absolutely.
Seems short to me for
so
would
364
for surgery
days.
and intervention. It doesn't for medication, but for surgery and interventions, that seems like a very short period of time. And from a, as was pointed out, from a patient perspective, I don't think they would consider the success to be if they want 1 day over 365. I think 2 years.
Let me say it again, right? First of all, we get to answer both, right? But my understanding is, if you will, over that time period, if you get a blip of benefit in the short term, we're counting that, and we obviously around the discussion, but that is a benefit. But if it's a question of durability, and let's imagine we had perfect follow-up data past 5 years, to get a benefit, an outcome benefit that is long-term, you have to see that benefit at 5 years. It has to persist until then. That's what we're going to go with, all right, or 3 or 4 years, long period. I would like to take, I promised everyone a 10-minute break. I'd like to stick with the 10 minutes, and then we are going to vote. Thank you. Which means, in terms of biology, panel gets preference. Hey.
which will never be done. So it'll never be
No, but at
done.
least they're paying me a lot of money for it. Do they pay a day per deal? They might actually be paying us.
That happens to me at CDC.
Well, I have to say, the way this is going, I think they're overpaying. Oh, you know what? I think. Can we get started?
I don't care how humid it is.
So I wasn't.
I'd like to get started, please.
I'm sorry for that. Literally, we're sort of out of my. He was just frustrated.
That too. Oh, yes, yes.
It's a common misperception. Two common misperceptions.
But between the FDA completely dropping the ball.
Years.
So much reframing of what they did ever since.
Again.
Okay, thank you all. Can I ask you to either take your seats or conversations in the hall, please? This is the moment everyone's been waiting for. One more clarification in thinking about this issue about question one, the issue of asymptomatic. I'm going to try as best as I can to remap this onto a regulatory framework with Dr. Hirsch's comments, very much in my mind. I think what is intended, in fact, I'm confident that what is intended from the question regarding asymptomatic patients is patients whose PAD is discovered through screening. So whether it is a narrow view of the symptoms that trigger the doctor or the evaluation, or a broader view such as happening to catch a history of reduced walking distance or something, those would be off the table. It is sort of systematic screening in a patient without symptoms of the disease. If that's the trigger, that's the bucket. So it's essentially the chain of events following screening is the question. I'm sorry for being away from my mic. Go ahead, Dr. Hirsch, although
Just to be clear, that's excluding the fact that 5 years ago I had a right iliac angioplasty and I've been feeling just fine seeing my primary care doctor. We're not dealing with that beneficiary.
That's not prevention.
Sorry?
That's not prevention at all.
I would think that documented prior history of PAD, assuming that was an intervention related to PAD, right? I would think that documented PAD puts you into a different category.
Peter,
Go ahead, Rick.
just
I'm doing the best I can here.
Let me just press you a little bit. It seems to me you've reframed the question from whether there are benefits for asymptomatic patients to the advisability of a screening program.
No, Rick. What I believe is I'm trying to define the cohort, not the question of screening itself, right? So if we were going to conduct a study, I think the entry criteria would probably be screening, but then it could have different interventions. But I'm just trying to narrow the cohort into those. But I think those two things are related ideas. I'm open to other definitions. We just need to be able to give Medicare some guidance regarding the cascade of events that could occur after a screening test is done.
So Peter, I don't know the best answer. These are very tough questions. But I'm going to again take a patient-centric CMS perspective. If in the United States of America fully half of the population, more or less, has no identifiable chief complaint, but has PAD with both functional impairment and high event rate, that means that our meeting and our panel is really excluding a huge population of beneficiaries. In contrast, remember, the USPSCF true screening population really hasn't been studied. So we're taking the first question and truncating it to a tiny fraction of the actual PAD cohort. And I'm just asking myself for CMS, is that wise?
We're going to take the questions, I believe, as written, and I take your point, of course, but I think it's perfectly okay. It is commonplace for the discussions to focus on narrow populations, and there's lots of people with lots of conditions who are not being considered. And that's sort of the best. I don't know how else to constrain this so that we can all be at least voting on the same thing. So, do I read the questions? You want to read the questions?
No, I just need to make a statement. All voting panel members, you should have your keypads. When it's time to vote, please press your vote of choice hard so that it will register. Also, when it's time to vote, we will need you to state your name and your vote for the transcriptionist and for those individuals on the webcast. So again, please speak into the mic, state your name and your vote, and we can begin. Yes, sir.
Okay, so I'm going to read the questions. The first question is, for adults with, and remember we're voting twice here, for adults with asymptomatic lower extremity PAD, how confident are you that there is sufficient evidence for an intervention that improves immediate/near-term health outcomes, which we as a panel decided constituted outcomes occurring within the first year after identification?
We're waiting on 3. Yes. 2, 1. If you're not sure, can you push your button one more time?
It won't take us twice if we do that?
No.
We're having a technology problem.
So just as a reminder, every panel member should vote? Okay.
Anyone's broken. Needs a battery.
Okay. All right, the mean is 1.4. You can see it on this screen. I don't know if we can fix the screen up here, which doesn't show the bottom. Oh, there we go. You can at least see. But the mean value is 1.4, and that's with all 10 panel members voting. Yeah, so I'm going to ask on the second question, which is essentially 1B. Let me read that. The same question for adults with asymptomatic lower extremity PAD. How confident are you that there is sufficient evidence for an intervention that improves long-term health outcomes, which we agreed as a panel were outcomes that were accessible up to 5 years? Or actually said at 5 years, given the constraints of the data. Okay, the mean was 2.8 there. Hold on one second. Excuse me. All right. I apologize. I've missed a process step, which I knew. I apologize. Hopefully we can regenerate this. I actually have to poll you now for your responses. So if we can return to 1A, you don't have to vote again, but hopefully the numbers will work out. Hopefully everyone remembers what they voted 15 seconds ago. On question 1A, on the asymptomatic, immediate, near-term health outcomes, Dr. Campos-Ocult, will you tell us what you voted?
I voted 1.
Dr. Carr? Yeah, or you can identify yourself or I can identify you. Go ahead.
3.
Dr. Carr. Dr. Sujay?
1.
Dr. Deo?
2.
Go, Dr. Lawrence?
1.
2.
That's Dr. Lefebvre. Dr. Lewis?
1.
Dr. Saliv?
1.
Dr. Swain?
1.
Dr. Zuckerman?
1.
Okay, and what are we doing? Go ahead.
Dr. Cormos, go ahead.
One.
That's Dr. Cormos. Dr. Leistig?
1.
Dr. Hirsch?
The outlier, 3.
Okay. All right, great. And I'd like to do the same for 1B. And actually, can I ask you to identify yourself so I don't have to do that? Doug.
Campus out called 2.
Jeff Carr, 4. Al Sujet, 2.
Richard Dio, 4.
Peter Lawrence, 4.
Frank Lefebvre, 2.
Sandra Lewis, 4.
Saliv, 2.
Swain, 2.
Zuckerman, 2.
Cormos, 2.
Listig, 2.
Hirsch, 4.
Did we get all the way through? Okay. All right. My preference is we're going to do the other voting, and then we will return to the discussion of each topic. Okay, so we're on to question 2. For adults with lower extremity intermittent claudication, how confident are you that there is sufficient evidence for an intervention that improves immediate/near-term health outcomes?
We're waiting on one vote.
Excellent. Can I poll you?
Campus out called 3.
Jeff Carr, 2.
Al Sujet, 3.
Dio, 4.
Peter Lawrence, 3.
Frank Lefebvre, 3.
Sandra Lewis, 3.
Saliv, 4.
Swain, 4, and we're not copying each other.
Zuckerman, 3.
Cormos, 3.
Listig, 4.
Fascinating. Hirsch, 5.
All right. And for 2B, for adults with lower extremity intermittent claudication, how confident are you that there is sufficient evidence for an intervention that improves long-term health outcomes?
We're waiting on one vote.
Doug? Go ahead.
Yeah, campus out called 2.
Jeff Carr, 3.
Al Sujet, 3.
Dio, 4.
Peter Lawrence, 5.
Frank Lefebvre, 2.
Sandra Lewis, 4.
Saliv, 4.
Swain, 4.
Zuckerman, 2.
Cormos, 4.
Listig, 4.
Hirsch, 5.
Okay, and on to question 3A. For adults with lower extremity critical limb ischemia, how confident are you that there's sufficient evidence for an intervention that improves immediate/near-term health outcomes? And remember, in this case, we decided that these were health outcomes experienced within the first 6 months.
We're waiting on 2 votes. Now 1. We need 1 more vote. One more. Just 1.
I think somebody thought they voted.
Can we just clear it and do it again?
Can everyone just press your button one more time? There we go.
Doug?
Campus outcome 4.
Jeff Carr, 3.
Al Sujet, 5.
DO 3.
Peter Lawrence, 5.
Lefebvre, 3.
Lewis, 5.
Sleeve 2.
Swain, 4. Zuckerman, 2.
Cormos, 4.
Listig, 3.
Hirsch, 5.
You know, there's been twice now where one more person said they voted 5 than registered on there.
No, we're...
It said 4 and there was...
Really?
Yes, I counted this time because I thought I made a mistake last time. If you look at that
Hold on a
number-
second.
Yeah, hold on.
They're pushing a button and it's being recorded electronically.
He's saying that it's not matching.
Well, what'll happen is, I'm going to have that green sheet, and we'll compare.
Okay.
We'll compare the green sheet.
And the green sheet's not the shortest.
Yes.
All right, fine, okay.
It's twice now, it's been off by one.
Okay, great. Last question, which people are already answering. 3B, for adults with lower extremity critical limb ischemia, how confident are you that there's sufficient evidence for an intervention that improves long-term health outcomes? That's only the right first 10 who vote, right? Okay. That's the distinction.
But don't you think I'm
Okay. It's impressive, yeah. You must be from Broward County. Go ahead.
Campus outcall 2.
Carr, 2.
Al Sujet, 3.
DO 4, or correction, 3.
Peter Lawrence, 5.
Lefebvre, 2.
Lewis, 5.
Sleeve 2.
Swain, 4. Zuckerman, 2.
Cormos, 3.
Listig, 3.
Hirsch, 3.
Great. Thank you very much. We're going to now cycle back to the discussion on each of the questions. And in the context of these questions, the discussions have thresholds. So if the vote is below, I can't remember if it's less than or equal. Okay. Yeah, so an average vote less than 2.5 means we will not further discuss the particular intervention. So in this context, 1A referred to near-term outcomes of asymptomatic patients that received a score below the cutoff. I remember 2.2 or something like that. Sorry?
What was it? The first one was 1.4.
Okay. So 1A, the mean was 1.4, which means we won't now discuss the questions related to it. But the next one, 1B, the long-term health outcomes with asymptomatic disease, was over the threshold.
Correct, 2.8.
Was 2.8. So the question to the panels, this, if you will, allows you to flesh out the question and the discussion and things like that. So please identify the specific interventions and associated outcomes in terms of long-term outcomes in asymptomatic PAD. And the floor is open. One of the I don't want to call it a shortcut, but one approach that we all could take, or some of you can take, is you can actually point to some of the literature, reviews, and other presentations that we've heard today, if you don't feel that cataloging every single thing is an efficient use of time. But the floor is open, and we're talking about long-term outcomes for asymptomatic patients. Go ahead.
I would just say current guidelines for both primary and secondary prevention have significant benefit on cardiovascular, heart, and cardiovascular fatality, anywhere from 20 to 40%. And that was the intervention I was thinking of, basically lifestyle, control of risk factors, and medical intervention where appropriate.
Thank you very much. So systemic interventions aimed at non-peripheral limb outcomes. I in no way want to curtail the conversation. I would take the view that that's a consistent theme we've heard throughout the morning. If there's a difference of opinion over those things, then let's continue to pursue it. I would rather now put that to the side. Again, with any objections, I won't do that. I'm just trying to keep the process going. With that off to the side, I would turn the question to both directed interventions and peripheral outcomes, given that you've just, I think, covered the waterfront of systemic interventions and non-peripheral outcomes, if you will, cerebrovascular and cardiovascular. I'm looking for interventions tied to outcomes in the peripheral space amongst asymptomatic patients. Evidence supporting those.
Just because there's silence, I mean, I think we heard from every speaker and from our Dukeites that there is no role in space for that. If we're saying again, as you define this, that this is a truly asymptomatic limb population, then there is nothing to do.
Dr. Swain?
With the exceptions of popliteal aneurysm and the AHA exceptions.
Okay, understood. All right, so thank you for pointing to, we know exactly where to look for that, to the AHA exceptions to the peripheral disease. Dr. Lefebvre?
I think I agree with the first
I can't, microphone please, I'm sorry.
I do agree with the first comment that we expect there is efficacy for antiplatelet agents and other interventions for patients with vascular disease. However, I think the reasons why I would rate this lower is I don't think we know what populations this is directed at. We say asymptomatic lower extremity PAD. I think we've heard here that's a very nebulous population. I think we heard the studies include a whole range of patients with all kinds of risks. I don't think we can say who needs to be treated. So I rated it lower because of that issue, because of the populations being ill-defined.
Okay. Dr. Deo.
Yeah, just to add slightly to that, I agree with the argument about systemic therapy. I think there's a little question in my mind that is effective and will have some benefit for these patients, but I have real reservations about recommending a screening program specifically for PAD as opposed to simply screening for risk factors in general.
Okay. Point taken. And, you know, the point of this discussion, we do not need to reach conclusion, if you will, on discussion, but I very much want to get the impressions and conclusions aired for the purpose of the transcript and for the purpose of aiding CMS in the future.
So maybe for the purpose of the transcript as qualitative data, unpublished, probably about 1/4 of current CMS beneficiaries have an ABI done or any PAD diagnosis or at high risk. So even though we're not advocating screening, Peter, and we don't know its role and there's no randomized trial, we unfortunately live in that world, as Dr. Beckman said, between marked, profound underdiagnosis and the disease that becomes evident. So I'm just putting that out there for the record.
Okay. Large reservoir of undiagnosed
Huge reservoir
disease.
of risk that is having real cost and health effects.
Okay, and in bifurcating this discussion, I want to make sure that I have not shortchanged the possibility that some of the systemic therapies have peripheral benefits. I didn't hear that brought up. I didn't hear it in the evidence, but I don't want to, that is a version of the 2x2 table that I should at least explicitly bring up and ask members of the panel if they feel the evidence supports peripheral benefits in the asymptomatic population of systemic therapy per se. I focused on, if you will, cardiovascular and cerebrovascular outcomes in the way I separated things. So that's the question to you also. Do you have a...
I agree with what you said. I was just going to, for the record, there are prospective data comparing Framingham risk score, family history, ankle brachial index, carotid IMT, and coronary calcium in the NHLVI multi-ethnic study of atherosclerosis, a cohort of 7,000 people, Yaboa, published in JAMA 2012, that could be used to evaluate the efficacy of a primary secondary prevention with those tools.
Sorry? That was Dr. Carr speaking.
Oh, Dr.
Dr.
Sujay.
Sujay.
I would just add the comment, there was one slide that correlated GFR with outcomes, and we know that if your blood pressure and your diabetes are well managed, the incidence of renal insufficiency or renal disease declines. So I would add that to the systemic interventions.
Okay, thank you, Dr. Sujay. Okay, thank you very much.
I didn't
Go
hear
ahead,
any
Dr.
direct
Salif.
evidence, and so I'm kind of the opposing point of view on this.
Can you speak closer to the microphone?
Sorry,
please?
I didn't hear any direct evidence that was positive on this. I felt that this was negative, and although the evaluation was the average criteria, and I think that would be valid for screening test, but I think this was negative. The presenters showed two aspirin trials that were both negative after screening for ankle brachial index, and then there was some discussion about lipid lowering, which I believe was, maybe in the high-risk people, but the lipid lowering is now widely recommended anyway, so I don't see why high risk would need to be identified through the ankle brachial index.
Okay, so when Dr. Salib, when you said this, you're talking about the long-term outcomes with systemic therapy.
Yes.
Okay. Does anyone want to pick up on this point? That differs, I think, from what Dr. Carr concluded. Is there a way to fill this in with evidence, or?
Well, if we're here to highlight evidence gaps, because again, I've been very
We can do
careful in
that.
saying we have to know what we know and then say what we don't know, so CMS, AHRQ, and investigators can fill in the gaps. We hardly reviewed the totality of evidence in this data-focused meeting today, and there's no way we could have done that. So there are at least 2 prospective trials. 4S was the one simvastatin trial. I can't remember the other lipid trial, where asymptomatic patients did not develop incident claudication, a robust pre-hoc defined endpoint. It's never been repeated. It's not been the focus of care, but there is some evidence out there. It's an evidence gap. Just because we don't know doesn't mean it might not be effective. And in the current Vorapaxar PAR1 antagonist antiplatelet domain, there is initial evidence, Banaka paper in circulation a year and a half ago, suggesting again that limb events actually are decreased by that particular antithrombotic agent. But we haven't gotten that granular today. So these are evidence gaps that could be filled in.
Okay, appreciated. I'd like to move on to question 2A, which had a 3.2 mean score, which again leads to a discussion about which interventions and which outcomes in the context of immediate or near-term health outcomes for patients with intermittent claudication. And let me actually propose that we'll further curtail within the limb, the peripheral outcomes. They need not be peripheral interventions, but peripheral outcomes as opposed to this kind of global set of cardiovascular and cerebrovascular outcomes. Dr. Swain.
I think the exercise results are very reasonable for the short term, and I'll make my comment for the next question for the long term too. So I think exercise for sure, and then there's the question of whether endovascular revascularization does. I think I agree with the Dukies that that's an intermediate level of evidence for that.
Do you want to distinguish between supervised and home-based exercise in that answer?
Supervised.
Okay.
Yeah, supervised. So I know the results of this is whether CMS will cover that, and I think CMS should cover supervised exercise for all these reasons.
Dr. Zuckerman?
I'm just happy to agree with that.
Oh, great. I love those comments. All right.
Yeah,
Dr. Lawrence.
Sorry, I gave it a 3, and the reason I did was because it really, to me, is dependent on the level of disease. So in intermittent claudication, the more proximal, the more the intervention is likely to be successful initially. So a claudicator with iliac disease will do dramatically well and have a very long survival with a procedure. In fact, the juxtarenal aortic occlusion can benefit greatly from an aortofemoral bypass, immediate benefit. But as the disease moves more distally and as SFA or infrapopliteal, then claudication becomes, to me, a much less compelling indication for doing either a bypass or intervention. So it's sort of in the middle where, to me, if it's distal, then it's a medical problem, and it fits into Dr. Swain's about exercise and maybe cilostazol, where if it's proximal, you have a 90% success with any of the open or endovascular approaches. So level of disease becomes critical to me in claudication.
Other comments? Dr. Lefebvre.
I just want to say, I don't think it's quite right to say supervised versus unsupervised are different interventions. I think it's better to say, exercise improves walking distance, and supervised exercise more than unsupervised, indicating there's like a dose-response effect. It's a more intensive exercise intervention. So I don't think we should just say supervised is effective and unsupervised is not. I think we should say exercise is effective, and the greater the intensity of the intervention, the greater outcome benefit you get.
Okay. And same question then for long-term health outcomes for intermittent claudication.
Well, I'll speak up.
And actually, it might be, you need not, but you've already, no, Dr. No, I didn't say you need not speak up. Well, I was about to, although that would be fine. I was about to say it may actually help for everyone else here who doesn't have a list of how everyone voted to say what your vote is. And I was going to say is you need not do that if you'd rather just speak, but it might help everyone anchor your comments. So go ahead, Dr. Hirsch. I'm sorry for cutting you off.
I'm not sure I exactly followed that. Just to push the panel to have an open discussion, again for CMS and for the audience, I was surprised at the relative downgrading of all of the interventions for claudication. And so just to provoke you all to speak up, whether it was the Duke presentation or the primary information offered, we have been presented evidence that pharmacotherapy, that supervised exercise, yes, based on the dose response, and endovascular intervention and open surgical, Peter, all work. And they have been studied, each of these, for at least 1 year, back to the bimodal TED distribution. So why is the level of evidence and confidence not higher? I'm confused.
Actually, that's a great way of asking a question that will also help answer some of the other discussion points. So I open the floor up to answer Dr. Hirsch's question.
I would say the
Dr.
answer
Lawrence.
is because the superficial femoral artery is the key of a lot of the discussions here, and the perception is that it's not durable, so that it may get immediate success, but there's a lack of durability. So it has to do, to me, again, with the level of disease. Not that it can't be initially successful, but that the durability is a major question with both open and endovascular approaches.
Peter makes a very good point, and for the audience that's not endofocused, it is true that from mid-thigh down, our patencies are not quite what we'd want them to be, although they certainly have markedly improved. But this gets to, our questions are difficult because we have 3 interventions, right? We have exercise, we have pharmacotherapy, and we have a range of anatomic possibilities for revascularization, yet we're asked to vote on all of them as one vote. It becomes challenging. If I were reading the transcript of the CMS officer later, I might be quite dour about the confidence that we could improve claudication for Medicare beneficiaries, when my level of confidence might be very high overall.
Dr. Campos, okay.
Yeah, I voted 3 and 2, and that's because the evidence report showed moderate level of confidence, moderate level of evidence, and it didn't go past a couple years. So I voted a 3 and a 2 for that reason.
I would agree. There were also very small studies. There were no large-scale studies, and I think the effect size wasn't great. The walking distance improvement was not that great. It was very small.
Can you identify yourself for the record,
Sorry,
please?
that was Dr. Lefebvre speaking. I'm sorry.
Dr. Swain.
Dr. Swain.
Yeah, I voted for, but it was, again, the heterogeneity of the durability, because, again, if it's a minimal claudication, I think durability should be decided out to 5 years. That's how I define long-term. If it were somebody that couldn't walk, 20 feet, that's a whole different patient. So the heterogeneity in this question makes it almost impossible to answer, but we don't have good durability for endovascular or open surgical interventions, and I don't believe we have good 5-year durability for things like exercise. So,
that's correct. So Julie, you made a very good point. I think what the group is saying is they want longer outcome studies for all interventions, and you're right, even for Clever it was 18 months only. Although if you had angina or you had some other symptom, severe migraine, you got 18 months of relief, my guess is you'd be happy.
And that was my
So
whole
let's
original.
not minimize what 18 months means to a symptomatic
And also,
Well, I don't think anyone's minimizing it. They've been separated, right, into 2 different categories. Dr.
I think
Lawrence.
another useful way to look at...
Sorry, Dr. Lefebvre, go ahead.
I'm sorry, Dr. Lefebvre. Another way to look at useful way to look at the outcomes would be if they defined the minimal clinically important improvement in walking distance, then report a response rate. That would be much more meaningful to me than just an average.
We saw no MCIDs for
Dr. Swain?
anything
We don't know.
anywhere.
Dr. Lawrence?
Yeah, without a quote, because this is from memory, but within the last year there's been a paper, I believe it was in JACC, that looked at patients and interventions, and I think it was exclusively in claudicators. In the United States, there are almost as many procedures done for re-intervention in less than 2 years than there are the initial procedures. So in other words, we've almost reached a point where the initial procedures are occurring at about the same rate as re-interventions, and that addresses the issue of durability.
Yeah, great. No, thank you. Other comments? No. Dr. Zuckerman, you still have your card up, I think.
Yes.
Go ahead.
Yeah, no, I just wanted to say, I think for many of these votes, and this is one, it was a conflict between what seems logically likely and what the data show, and the data just weren't very good. And so even though it seems like if people exercise or have some kind of successful short-term benefit, that would help them in the long term, but we just don't have the data to show it.
Okay, thank you. On to question 3. The issue is critical limb ischemia, and in terms of interventions and outcomes affecting immediate and near-term health outcomes, interventions. So, and again, separating out those things that are systemic and targeting other parts of the body other than the periphery.
This is Julie Swain. Again, you know, as I think it was AHA or ACC, you know, more blood flow. I mean, that's established, more blood flow, heal wounds. So for short term, I'm into the heal wounds, get rid of rest pain, and I think the evidence is fairly good that that occurs. I voted for on that one.
Let me ask you a point of clarification. Again, this is not my area of expertise. What I heard was that there were no comparative studies that were at least a high enough level of evidence to get into the Duke review, or either they predated the Duke review, where usual care or non-intervention was a control group?
Yeah, because you know nowadays really the standard of care is to intervene. I mean, that's the standard of care. So the idea that you're going to have a comparative study of do nothing and let them sit there and really hurt and have a stinking wound and before you amputate, or do something. And, you know, on this particular subset, I think it's the provide more blood flow. We have good short term of healing. We've seen it from the practitioners and all of us who do vascular surgery, heal and get rid of pain and make the patient more comfortable. And long-term wise, most of them are going to die pretty soon anyhow. So if we say long-term is 7 months or 8 months, then make them more comfortable as part of the intervention and the outcomes that you all are looking for.
And Dr. Campos-Outcult?
Yeah, I think this is the classic example where observational data can be upgraded, because the magnitude of effect of doing nothing versus doing this is quite large. And so you don't have great studies, but you can upgrade them because of the observational magnitude of effect. So that's why I gave it a 4, even though I don't think the studies are particularly robust.
Yeah, and I have a big problem of the graphs we saw on several slides of length of life for vascular intervention or those who have amputated, and the people who amputated have a shorter lifetime. I mean, there is no comparability between those two groups of patients, and I saw no propensity score analysis studies done of that. So I think those are just, and the idea to have another MEDCAC panel on amputations, I don't see a reason for that.
Certainly one of the evidence, this is
Dr. Lewis.
Dr. Lewis. One of the evidence gaps would be the compression devices and hyperbaric treatment, maybe in the patients who are not candidates for intervention.
Okay, yeah, we didn't hear much evidence about those, but obviously saw some dramatic pictures. Dr. Lefebvre, do you have something else to say? You have your card up?
I just want to comment on I gave it a 3. I do agree that this is an issue where we could accept a lower level of evidence. We wouldn't need RCTs. If you have a patient population that truly has no other alternatives and is heading for limb loss, then certainly this would improve outcomes. But the reason why I only gave it a 3 and not higher is because I think that's a slippery slope at selecting the patients. And it's very easy to think, you know, that it's not easy to select just the patients who are going to lose their limb. It's going to be hard, you know, and you might end up selecting patients with less disease and end up potentially even doing harm. So I think that kind of threshold of where to intervene and could we truly define a population that has no other alternatives or going to lose their leg, I think is questionable. So that's why I gave it just a 3.
And Dr. Carr.
My thinking on this question, I voted a 3 and 2, is that an ounce of prevention is worth a pound of cure, that there's tremendous investment in resources here at the end, and I think the speakers and the public speakers did a good job indicating that there's a huge reservoir of PAD out in the community that is undiagnosed, and that I would urge CMS to develop strategies to uncover clinical disease that's simply not manifest and encourage trials that would allow us to better risk stratify these people with disease and develop strategies rather than continually going from simply asymptomatic to symptomatic and critical limb ischemia. I think there's a lot of opportunity to target, through biomarkers, through genomics, through risk factors, not necessarily imaging or diagnostic testing, but there are probably ways that could more effectively risk stratify and identify at-risk women and minorities that have evidence of peripheral arterial disease, as well as treatments that could be more effective.
Dr. Saleev.
Yeah, I guess I downgraded it because there was only the one trial, but I did actually appreciate that there was quite a lot of observational evidence presented in the TA, and so it was helpful, but it didn't sway me further. I just think that it is doable. I agree with other speakers that some of these can be studied observationally, and stronger evidence could be provided that way in the future. So that, I think, is a gap. And I think the trial that's underway that was presented is helpful as well, and in terms of answering this question farther down the road.
Dr. Lawrence.
Yeah, I think the reason that there are not prospective randomized trials is because it would be unconscionable to not treat patients who have critical limb ischemia and a treatable lesion. So, I mean, this is evidence that's 40 and 50 years old. And it would be like saying that we need a new randomized trial to justify the use of heparin and warfarin for PE. It's not going to happen because it would literally be negligent to have a patient with an arterial lesion and true critical limb ischemia. Now, rest pain is always a little questionable because that can go either way, and sometimes patients can sit with that. But if you truly have an ischemic ulcer, gangrene, and don't treat the patient, I can't see any rationale or justification as long as they have a treatable lesion. So to me, this has to both early results and long-term. They need to be a 5. This is the only option for these patients, and it's just a question of what kind of treatment they're going to get, not whether they get treatment or not.
Okay, thank you. Marcel, do you have something else? Okay, let me move on to B then, which scored slightly lower than the immediate near-term health outcomes, the long-term health outcomes, critical limb ischemia, and using the rule that we've established, this is outcomes durable to 2 years amongst these interventions. So again, it's a limited number of interventions, of course, that have come up. And I guess the question is, discussion around those interventions and outcomes. Is there more detail or texture that we can give CMS around these outcomes and interventions? Great, I managed to pose a question in a way where I silenced everyone, which is, of course, my goal. Can we, all right, and I'm going to circle back one more time here through the 3 questions. There is another discussion point that we need to bring up, and I've grouped these because I think it's to some extent they go together. But the second bullet reads, considering, and this is for each of the 3 questions, considering the heterogeneity of the Medicare population, discuss which subgroups of the Medicare population the evidence shows are likely to benefit or likely not to benefit from intervention. And so I'll take these in order, beginning with the asymptomatic population, but then again, disagree with me as you would like. I believe the answers to these will generalize across the 3 questions, but again, correct me if I'm wrong. And Dr. Carr, you still have your tent card up, but Dr. Swain.
I just don't think we have enough data for subset analysis. That's the problem. And the biggest subset I see is diabetes or no diabetes. That it may be that doing let's say open endovascular surgical intervention in diabetics may well give you better long-term results, or may well have a blunted long-term effect, depending on the control of the diabetes and all that. So again, the data is just, if there's not enough data for the aggregate, there's certainly not enough data for subset analysis to identify Medicare populations.
And would that, your view of that, cut across all three categories, all three questions?
Pretty much so.
Okay, fair enough.
I don't know about critical limb ischemia. Again, I really think you supply blood, but the other two, for sure.
Fair enough. Dr. Carr.
For question one in asymptomatic, there's a fair amount of large-scale data that subclinical atherosclerosis in people with peripheral arterial disease predicts cardiovascular mortality and death, especially in women and minorities and untreated group. And so I think that there are data that could be reviewed that would justify more aggressive prevention in these at-risk populations and reduce morbidity later in Medicare beneficiaries' lives.
More on that point or something else, Dr. Sujet?
I would just make a general comment. I mean, the literature regarding depression as a comorbidity and its impact on coronary heart disease is irrefutable, and there's been not much discussion. We had one case presented of a gentleman who continued to smoke and did all this other stuff, but I did not hear the word depression come up in the presentation. And so, we're going to talk about general care of the total patient. I think depression screening, since it's indicated and recommended, ought to be a general part of the evaluation of patients with suspected PAD.
Thank you. Dr. Saleev.
Yeah, so I think to generalize maybe the last couple comments, I think it is the multiple chronic condition people in the Medicare population who would benefit greatly. You know, yes, it might be diabetics, it might be those with depression. You know, there's many different other chronic diseases, and I think there was a nice slide from someone about kind of the overlap of coronary artery disease, cerebrovascular disease, and PAD. But I would just say it extends to a variety of chronic diseases. And, you know, we don't know much. It would be nice to know more. And so the studies need to kind of ascertain the chronic diseases, the comorbid diseases that are accompanying this, so that it can be understood a little bit better. And, you know, this is really a very high-risk group with the PAD, I believe.
Yes, please.
So just following up on what Dr. Swain said.
This is Dr. Kormos speaking. Go ahead.
Sorry. I also saw a fair amount of data getting back to the issue that there's a differential in presentation, especially in intermittent claudication, based on gender, race, age. We mentioned diabetes, and there were a few others in there as well that if trials are going to be designed in the future, then they probably need to adjust for some of these differences, and it goes for some of the things. And it actually gets to the point, I think, that Dr. Hirsch also meant, that we talked about asymptomatics, but those asymptomatics could include people with previous peripheral vascular disease, and that's a subset that doesn't really get addressed in any of this.
Thank you. Okay, moving on then, that's the end of the discussion of the questions and the voting and the subsidiary discussions around those. I do want to leave the floors open if we, in the next discussion, come back to some of those things. That's, of course, fine. This is supposed to be a free-ranging discussion. But we do have some additional discussion topics that I think we've already, some of the comments have sort of bled into this area already. They are to discuss the important evidence gaps that have not been previously or sufficiently addressed by the literature, and to discuss any apparent lower extremity PAD treatment disparities and how they may affect the health outcomes of Medicare beneficiaries. I'll start. I'm not providing the answers. I'm just going to repeat some of the things I've heard during the course of the discussion. In terms of evidence gaps, I've heard very consistently today that there are important subsets. Of course, this is not my disease area, but diabetics, non-diabetics, there's gender, or pardon me, sex difference, race, particularly African Americans, location of the lesion. These are all themes that I've heard from multiple people over the course of the day as important ways of thinking about this condition. And then interplay between other types of vascular disease, non-vascular disease such as depression is another evidence gap that has come up. And then the issue that really is revolved initially around the questions, but very much around the discussion around clinical trials design, the tightness of the definition of the cohort, the tightness of the definition of the outcome, and in the middle of there is the tightness or looseness of the definition of the interventions, given a rapidly changing, particularly on the device side, rapidly changing landscape of devices. So that I already have heard all those things. If you want to take any of those off the list, let me know. If you want to add things to the list, please have at it. Dr. Lawrence.
Yeah, there are two that I would just suggest you at least consider adding, although you touched on them. One is the unreconstructible patient. The patient who either because of prior interventions or prior procedures, or they just have such diffuse disease that there's no available treatment, has a high likelihood, and particularly those that have wounds or have a chronic disease which will, like a wound, which takes a tremendous amount of resources. And then the other is to address specifically infrapopliteal disease. I think that maybe aortoiliac has gotten most clearly defined as far as management. FemPop, as we've heard today, has a lot more evidence coming up, but infrapopliteal disease and very distal disease, it particularly occurs in diabetics, and I think that that's going to be an area that needs to have much more investigation and many more studies than we currently have now.
Fair enough. Other, Dr. Cavanaugh. Sorry, Doug.
I think the diabetes question is particularly interesting and important. Peripheral vascular disease and diabetes together is a bad combination. And I just think that there's going to be differences in treatments that need to be fleshed out. Secondly, the disparities. We've documented disparities, but I'm not sure we've got a lot of research on why the disparities exist.
We're going to get to that, and we're not on that question.
All right. So I'll hold that one. I think the research on better ways to find symptoms, which has been discussed, is probably another one I would add. And then the obvious one is comparative effectiveness. We just don't have very good comparative effectiveness data.
Thank you. Dr. Deo.
Yeah, in terms of subsets that I think need more attention, we tend to think of everybody in the Medicare population as old, but I think there's an important difference between young old and old, and the risk-benefit equation may change with increasing age, and I'd like to see more studies that really segregate out the old population and help us inform us better about that group.
Fair enough. And I assume for all of us that cut point moves up a year about every year. No, the point is taken. I'm sorry. I don't mean to be silly. Dr. Carr?
Just for the record, I was going to point out that, and this may be obvious, but that atherosclerosis is the disease. And within atherosclerosis, there are manifestations in different vascular beds: renovascular, peripheral arterial, coronary artery disease, cerebrovascular. And then I would just for the record say that there are large and medium arteries that could be involved with the disease, and small vessel disease in the kidneys or in the distal legs. And that as CMS thinks about this, just like they would lung cancer, realize that it's one disease that may have multiple manifestations based on where the disease metastasized to or the organ system involved. That complexity confounds a lot of this discussion, but an understanding of that pathobiology will be very helpful as we move to precision medicine, where we look at genetics, we look at evolving treatments that are near to being available to the Medicare population that will have multiple organ system effects across the vascular system. So I think thinking of peripheral arterial disease in isolation from these other manifestations of atherosclerosis will not give us a comprehensive picture of how we can best manage it in the Medicare population.
Thank you, Dr. Carr. Dr. Deo, is it your card, Dr. Lawrence's? Doctor, are you done? Dr. Lefebvre.
I just wanted one more subpopulation, I think, would be by severity of the PAD. I didn't see any studies that restricted or stratified patients by mild, moderate, or severe level of disease, and I think I'd like to see studies segregated by either ABI or even better, maybe by functional status in terms of interventions directed at different stages of disease.
Thank you. Dr. Sleeve, I guess you don't have a question. Dr. Swain?
It's subpopulation is those who are having a second intervention, because that's a specific one. I disagree again with the BEST trial that an intervention that can lead to death or limb loss, which is endovascular surgery or anything, that it is not a minor procedure. So we have that particular subset of re-intervention, which apparently is very common.
Dr. Zuckerman, thank you.
I don't think it was part of this discussion so much, but to emphasize what someone else said before about the importance of having better data earlier in the process, and so that when they're more likely to be short and long-term benefits, and just having better data on, we have to figure out how to do screening that works and that leads to interventions that work. And I don't think we have research that shows that. Maybe there is no way to do it, but maybe there is, and we just haven't gotten the research done yet.
Great, thank you. Dr. Lawrence.
Yeah, just a brief comment. It's interesting to me that in all of the discussion today, I haven't heard the word stem cell mentioned once, and yet there have been like 5 or 6 trials of stem cells, and many people in the cardiovascular area think about the lower extremity as the place where the role of stem cells will be investigated. So not that it should be thought of now as a therapy, but when you're talking about gaps in knowledge, I think that that approaches, that's why I mentioned unreconstructible disease and restenosis, the patient has multiple procedures, is that stem cell may have a role there, and certainly that's something I think we can encourage CMS to support, and there will, I think, will be research in 20 or 30 years from now. That may be all that we're talking about at a conference like this is the role of stem cells in lower extremity PAD.
Okay, well, that goes into the, if you will, to categorize it, that's a sort of a, let me call it new technologies, right? Not well understood. I wanted to ask a question about that, which is the compression devices. We've heard a fair amount about it. It's not an area I know much about. Is there an evidence gap there? Or was it that our reviews didn't take in what we should have taken in?
Yes, there's an evidence
Hirsch?
gap. Clearly, we were presented with a number of trials that demonstrated some initial efficacy, but the sample sizes are small, the descriptive populations are not necessarily representative, but there is at least a biological reason to presume there might be efficacy. So there is a research gap.
And again, apologies for the naivete. Is it possible that that could be side by side with other interventions for critical limb ischemia, or does it have to only be, is it your expectation that this will only be for non-operable patients?
Well, Hirsch again, this may come off Peter's comment. For all the things we study, when we tend to combine different syndromes, CLI and claudication, asymptomatic and claudication, we tend to learn very little because already the panel doesn't like the sample sizes. So it's always wise to have a relatively well-described single population. A CLI compression trial would likely be distinct from a claudication compression trial. Peter, your comment about cell therapy, the National Heart, Lung, and Blood Institute sponsors the CCTRN PACE trial. I'm the national co-PI looking at claudication cell therapy, but there's only 80 patients. If you didn't like Clever and you didn't like the other studies of 100, you're not going to like this either. So I think what we're maybe saying to ourselves back to CMS is, since it's been very, 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 how many varies, hard to actually get people to be aware of the trials and to be randomized, again, like other new therapies, there isn't a reason to incentivize research participation to have adequate enrollment and adequate sample sizes, or this field will never move.
Point made. Thank you. Dr. Swain.
Well, I'd like to second that for virtually all the trials. That, I think CMS, one of the first ones to require payment that you be in a trial was lung volume reduction surgery. And I think for a whole lot of these devices and trials, that they should go on, and the way to incentivize is the only way you're going to pay for it is to be in a trial. And that works well because the off-label use and everything is impossible.
But Julie, if you're going to ask for that, I'm going to ask for parity. It's not just device trials, my device maven, but it's equal for pharmacotherapy and behavioral therapies.
Oh.
Thank you.
Very good. I agree.
Dr. Zuckerman, do you have another comment?
No, I'm sorry.
Okay, that's all right. Thank you. So along the lines, I've heard a call for coverage under evidence development is the technical term for that. There were also discussions about registries and quality improvement in the context of registries. We heard about a large registry going. Is it reasonable to argue that there would be subset differences in outcomes based on institutions participating in those registries as well as, or not? I'm seeing head nods, which is one of the things we can't record in this meeting.
Swain says yes.
Dr. Lewis.
Well, we certainly saw differences in rates of such things as amputation, et cetera. I don't know why we would think that there would be homogeneity across the country in these things. So I think looking at heterogeneity of site is very reasonable.
Dr. Sleeve.
So yeah, I think one thing to incentivize also is the pragmatic trial, and I think we heard a pretty good example of one, although I didn't hear enough details today about that trial. But I think that the reason to do it is to allow for wider strategies for treating these problems, and have some ability to compare them and enroll a variety of different specialties, I think, as we heard, to do the procedures and treat the patients. So I think, that pragmatic trial idea, it didn't sound like it was fully pragmatic, and I know it's a spectrum of pragmaticness, but, and to me also, I think this gets to that idea that people were mentioning of, personalized medicine, but, an individualized approach that involves the patient is needed, I think, in this, that I don't think we heard too much about, because what are their priorities? And older people have different priorities. They don't all have the same priorities, and it's not related to the diameter of a certain vessel in their leg. So it may be related to their functional status, and I think that was usefully examined here. So I think the studies of patient preference are also a gap that we should try to encourage some work there.
Great, thank you. Dr. Leistig.
So you'd asked the question about the registries and about seeing the heterogeneity by sites. So I think in the presentation we'd seen from the registry result, I did not see what would deem to be sufficient accounting for the possible differences in the patient populations by sites. So I'm less interested in seeing that sites have differential performance than seeing, after having made appropriate adjustments, so you have comparable patient population between those sites, you might then have differential performance. So, when we are looking at these observational data sources, we need to take appropriate steps so we can draw the appropriate inferences from it and make fair comparisons. But then I'd also just point out too that within the context of registries, there is a difference between doing a census and doing a sample. And if you do the samples right, within stratified sampling, for example, you can make very good inferences about targeted subgroups. It is not necessarily a requirement that in order to have effective findings from a registry, it needs to be a census of everyone with a particular approach. And it's appropriate not to conflate those two issues.
Agreed. Dr. Hirsch.
I was just going to add one more positive comment to get us out of our depressive rut. No, but seriously, I'm worried a little bit today, back to disparities and unanswered questions, that we somehow focus on what we don't know. And for those who presented, there's an awful lot of consensus out there that is well-grounded. I'm conservative and scientific base. And gosh, I don't have quite the date right, but PAD performance measures, the 6 to 7 things that every vascular site thought were appropriate exist and have been published and peer-reviewed. There's no controversy. It was simple things, as you've said before, like statins, appropriate antiplatelet therapy, appropriate ABI use, appropriate graft surveillance once you've had your bypass graft. And these disparities that exist within registries and practices are a problem, aren't they? Because even when we know what the CMS beneficiary should do, if there is this huge disparity, we already know scientifically with dissemination research it's easy to abolish disparities by measuring these and then having appropriate pay interventions. So I just want to put on the record that the performance measures that exist serve for CMS as an excellent guidepost to a bare minimum of what we know.
Okay, thank you. Dr. Swain, do you have another comment, or you're no,
This is totally different than the others, but is there a possibility with CMS for their big bucket of money that they have to help support the registry? Because the biggest lack I see in the SVS compared to the STS is on-site audit. Once you start doing some, doesn't matter how many you do, it's amazing how the data gets changed when you're at risk of having a audit, not just a statistical audit. That's certainly important, but on-site audits and then a requirement to enter data in the registry for payment, I think would go a long way. And and audits are the most expensive part of any of these, is having help pay for at least some number of percentage of sites audits.
Let me move on to the last. I can answer that question, which is I think it's unlikely to have a mechanism in place. But you know, as a condition of coverage, there's other financial incentives for institutions to do it, right? The last question is discuss any apparent lower extremity PAD treatment disparities and how they may affect the health outcomes of Medicare beneficiaries. Dr. Sujet.
Yeah, Al Sujet. Obviously, we've seen disparities in outcomes among different populations. And given the evidence gaps, it begs the question as to how we're expecting primary care providers to assess and manage these patients. You can look at New York's just in its 7th month of the Nurse Practitioner Modernization Act, I think it was the 17th or 18th state. So the point is, it brings me back to 2002 with the All Hat trial, and we all got carted off down to Texas for the dissemination training. And I think a big piece of this needs to be when we have the evidence, it's fine that we know it, it needs to be disseminated and diffused into the practice population, so when patients do show up, they're assessed and managed accordingly, and I think CMS can play a big part in that.
Okay, thank you for the comment. So you skipped over the answer to the question, so let me fill it in, which is that there appeared to be at least large outcome disparities and large treatment disparities in terms of amputation rates, at least by race. This is what I saw on the slides, correct me if I'm wrong. And very large effects due to income as well, or at least using ecologic metrics of income, such as income in a zip code or something like that. And I think you went further and said, okay, given that, what should we start thinking about doing about it?
I can tell you just as a simple example, I mean, thiazides was the cheapest way to treat hypertension. The prescription rate was tracked after the implementation of the dissemination product, and the curve kind of went like this. It had been going like that for all the private. So it's an effective intervention. It does work, and it does improve control rates depending on what your target is.
Other comments about disparities? There was an earlier comment that suggested that subsets of patients, probably the ones showing high rates of amputation, for example, African Americans, might be evaluated differently. That maybe I think what I was at least reading between the lines that the approach in African American, maybe the screening approach should be more aggressive or started earlier, or that the triggers for evaluation of vascular disease might be set at a different threshold in populations at higher risk of these very bad outcomes. If I didn't hear that, then please correct me.
You heard correctly. So the general global epidemiologically accurate disparities is African Americans, Hispanics, Native Americans, yes, the extreme elderly who are still viable, smokers, diabetics, and people with stage 3, stage 4 CKD all have the highest CLI and amputation rates. But the disparity has at least 4 components which could all be solved. One is access to research again. It's true that women are underrepresented. There's almost no minorities in our current research portfolio. It's unbelievably adverse. Access to diagnostic interventions, a simple ABI or duplex. The third is access again to treatments. The thiazide motif is true. More potent antiplatelet agents are better, and they're not used as well in the lower socioeconomic groups. And then lastly, again, obviously rehab and outcomes. So all these disparities exist. As my colleague Dr. Beckman says, PAD by itself is the disparity. It doesn't matter if you're white, black, you live in downtown Minneapolis or Rochester, you're not going to do very well. But yes, we could serve to focus on those high-risk groups very, very well.
Other comments? Dr. Suchet, do you have another comment or no? Okay. No, okay. Great. I want to thank the audience for putting up with us. I want to thank the panel for putting up with me, and for Medicare for giving us the opportunity to have this discussion, and for the presenters for what is obviously hundreds of hours of work preparing for this combined for very, if you will, very long runs for very short jumps in some cases. But thank you very much for the broad perspective and for the academic discussion with nuance. We are going to essentially wrap up. That is essentially my closing remarks. The purpose of this committee and of FACA-type activities is to have an open public dialogue around issues that hopefully will do a number of things, not only help the agency contemplate important problems, but also drive a research agenda. And this room is full of people who are thinking about research agendas, and hopefully eventually drive policy, although that Medicare would never say that is true. You know, when you hear calls for supporting registries, hopefully there's people a few miles south of here hearing that as well. So thank you again, all of you, for your time, and I want to give the microphone to Tamara.
Thank you, Dr. Bach. Thank you for being the chair today. It was a great panel. It was a great day. Very impressive presentations, very impressive panels. So let me just reiterate what Dr. Bach said is thank you very much for everything you've done today. It's been very helpful. We have a lot to take back, and we will be looking at this over the next 6 to 8 months to see what we will be doing next. So again, thank you very much.
We are adjourned.
Okay, what time is our presentation?